Hello, everyone. Could you all please take your seat so we can start the symposia program for today? Hello, so I hope that everyone is ready for the symposia today. Can everyone be seated? Good morning, everyone. Good morning. Dear distinguished guest, oh, sorry. Yeah. Dear distinguished guest, dear Congress participants, it is with great pleasure on behalf of the IPSF Executive Committee to welcome you all to the Educational Symposium of the 60th IPSF World Congress 2014. Throughout the history of IPSF, the advancement of our pharmacy education has been integral to core mission of IPSF. And every year, the Educational Symposium has been a prominent part of the IPSF World Congress, as it serves as a valuable platform for eager minds from all over the world to learn about how pharmacy as a profession is moving forward each and every day, every year. Today, 6 distinguished speakers are here with us to share their most valuable insights and experience on the topic of professional recognition of pharmacists through education. At the morning session of today's program, we will explore how pharmacists are being recognized professionally as a part of multidisciplinary healthcare team, a healthcare provider, and a member of community in general. While the afternoon session will be focused on the necessary skills and competencies needed to improve the professional recognition of pharmacists and the steps needed to further advance the pharmacy profession. It is IPSF's mission to improve public health by advancing pharmacy practice and pharmaceutical science, and also responding to global challenges in health education, and workforce strategies. And with that, I hope that at the end of the Congress, with the additional knowledge that we acquired today, we can return to our home countries, share this knowledge with our peers, and start taking active participation to serve these missions. I wish you all enjoy the program for the symposium. Thank you very much. To start the symposium, I will introduce the chair for the morning session for today, Professor Ian Bates. Professor Ian Bates holds the chair of pharmacy education at the UCL School of Pharmacy as head of educational development and is a faculty fellow of the Royal Pharmaceutical Society. He is seconded to the National Health Service in London as academic lead across the university teaching hospitals. Professor Bates is the director of educational development for the International Pharmaceutical Federation, leading an international team appointed by FIP working in partnership with WHO and UNESCO. And additionally, he is the editor-in-chief of Pharmacy Education Journal, an international peer-reviewed research journal hosted by FIP. He is a fellow of the Royal Pharmaceutical Society, a fellow of the Royal Statistical Society, a fellow of the Royal Society of Public Health, and a trustee for the European Pharmaceutical Students Association. Please join me to welcome Professor Bates to the stage.
Start my machine. Well, good morning, and thank you, IPSF, very much for the invitation to come to this lovely city in this lovely country, which I have a long history with. I started drinking port wine a long time ago, and I was introduced to it in this city. In fact, Bill here, stand up Bill and show everyone here, Bill once took me to a dinner in Porto when I was a very small boy, I think I was, and made me stay up very, very late in the evening drinking port wine in this city. So I remember that very well, Bill. So what I'm trying to do is to fill in time now as I try and get my computer to work. Here we go. Great. Okay, lovely. So today's day is all about education. But education comes with many different dimensions. At the moment, I suspect most of you here are pretty well focused and obsessed with undergraduate education, initial education, entry into our profession. But of course, education continues lifelong, and certainly for regulated healthcare professions like pharmacy and medicine, for example, the continued progress and development of practitioners is a key feature of health service delivery. So, although you're all probably, how many of you have graduated already in this audience? Yes, so maybe slightly less than half, and If you're still studying at college, yes, that would be most of you. So these times will end very soon. I don't want to start on a depressive note for you, but your days are numbered at university. And then you'll be let loose into the wild, and you'll have to start earning your living and to develop your skills and your behaviors and your competencies as you begin to deliver new services, clinically oriented, medicines expertise, pharmaceutical care oriented service. So it's really important that we have an overview of the whole spectrum, the whole scope of education. And that's what we're going to try and do today with you. So I'm going to start off talking about the workforce, which is the way that we describe the people working in pharmacy, from undergraduates all the way through to those people who may be about to retire from pharmacy. But we need to consider the education of the workforce. And because this is an international conference, we're going to start with the first half looking at the global workforce. And I'm going to show you some data which you might find very interesting as young professionals. Following on from that, we're going to talk a little bit about competency and capability of the workforce as a whole. And then later on this afternoon, Dr. Andrea Bruno and Dr. Catherine Duggan will be talking about mechanisms and tools and processes by which these things can be implemented. So we're going to start with the sort of whole big picture, and then we're going to dig down into the things that really matter to you about how we make it work. And rather pleasingly, it's just occurred to me that we've got Andrea Bruno followed by Catherine Duggan. So that's A, B, C, D, isn't it? I like that. Very good. Okay. All right, let me try and focus on this rather than having my brain move in other directions. Let's think about the workforce, first of all, and what it means. Well, you're the start of the pharmacy workforce, the global workforce as well as the national workforce of the countries of which you belong. So that's you as students, that's my esteemed colleagues down here, Professor Altier, Professor Eckhart here, who are deans of schools. So the students, schools of pharmacy are the starting point, if you like, of the workforce. But you are part of that workforce. You're part of the production of the workforce. Sort of allied to that, many countries have this sort of pre-registration experience, a sort of internship where you've mainly finished your studies, but you haven't quite registered yet as a pharmacist, but it's kind of like part of that initial training, if you like. And then we have the workforce itself, the registered, regulated pharmacists who work in nations, which is a big thing, quite a big thing. We're not quite sure how many pharmacists there are in the world. We've done some counting of numbers, but we don't know quite exactly how many there are. We know that FIP, for example, represents about 3 million pharmacists and maybe 4 million pharmacists and pharmaceutical scientists. So that's quite a large number already, but it's not the entire number, I don't think. One of Andrea's jobs down here is to count how many pharmacists we have in the world. So we're still waiting for the answer for that, Andrea. Another 10 years, maybe? We'll see. But the workforce is not static because we lose people from the workforce. We obviously lose people because they retire from their jobs. They get to be older, so they stop working, they retire. We lose quite a lot of people for things like career breaks. So women, for instance, who may leave their jobs to start a family, they may come back into the workforce later on, but having these maternity breaks is quite common. And that's actually a challenge for pharmacy, as we will see in a few moments' time. And we have those people as well who get into the workforce and then leave and they take up a job which is not pharmacy related. It's a small proportion, but it's a proportion we need to consider anyway. So we have you going into the workforce and we have people leaving the workforce. And the difference between the two sort of accounts for the size of the whole workforce. And for some countries, that's now a problem, a real problem. I could even say in Portugal, it's a problem, because we are seeing the entry into the profession sort of at a greater rate than what we're losing from the profession. So there's more schools of pharmacy being opened up, there are more students studying pharmacy, there may not be jobs to go to. And for some countries, this has now become an acute crisis, and we'll have a look at that very shortly. But in this big picture that's on the screen there is educational development at the core of many of the processes. So with undergraduates and schools of pharmacy, obviously, it's about educational development. With pre-registration, there's an educational component. And in fact, with your career stages, as you start off in your early careers, as you move into more advanced jobs, more advanced roles, then there's an educational component there as well. So we want to try and look this morning at the whole thing from a very macro view. And FIP, over the last few years, has been producing a number of reports, often data-driven reports, to try and characterize the global workforce, because FIP, ministries of health, governments, WHO, all of these significant stakeholders now need to know what we are doing with our pharmacy workforce, okay, for all sorts of reasons, which I'll come on to. And in next month, in September, we'll be launching our most recent report. You can see is characterized by a new color. We've changed color. Do you like the color? Let me just do a quick poll. Raise your hands if you like the color of our new report. No one likes the new color, Andrea. Andrea chose the color, and no one likes the color. Only joking. Let's start here then. We have countries which have a general shortage of healthcare workers. WHO estimate we are short of around 7 million pharmacists, doctors, midwives, and nurses. If we are to achieve healthcare equality throughout the world, then we need 7 million more pharmacists, doctors, midwives, and nurses. That's quite a large number, quite a large number. And if we look at the pharmacists' numbers throughout the world, and we map those numbers to the country, the size of countries, we get this very strange map here. So you can see, for example, that Africa, it's in the middle of that picture, has more or less disappeared because we have very chronic as well as acute shortages of pharmacists in Africa. You might notice that India, for example, the big yellow blob there, is rather large because they have lots and lots of pharmacists in India. Europe is looking quite large. The big, huge purple country right on the right-hand side there. Any guesses as to what country that might be? Japan. That's Japan. Has one of the largest densities of pharmacists in the world, does Japan. South America, looking a little bit slim. Canada, looking large, bigger than America for once. Where's my American colleagues at the front here? This is the only map you will see where Canada is bigger than America, gentlemen, there. So we have shortages, generally speaking, although perhaps in some countries we don't feel it, some countries we may have too many. Generally speaking, throughout the world, we have shortages. We have imbalances between private and public. We have imbalances between rural and urban in many countries. Australia is a good example where all the pharmacists are concentrated around the urban areas, around the edge of the country. We can't get pharmacists into the middle of the country in rural areas. So Africa is a similar thing. South America is a similar issue. We need to make sure our roles are connected with local needs, and we'll be coming back to this issue repeatedly today as a point. And migration. I'm really interested in how pharmacists migrate at the moment. We know an awful lot about how doctors migrate from country to country. We know even more about how nurses migrate from country to country. We don't know very much about how pharmacists migrate. Just as I know I keep asking you to raise your hands, but this is interesting for me. You come from lots of different countries in this audience. Are any of you considering leaving your country to go and work in another country when you graduate? Look at that, that's astonishing. That's nearly, I would say, a third of you are thinking about going to another country to work. I think this is a real challenge for us to try and map this and to get better ideas of migration. So let's start with looking at the global data, and there is a relationship between the number of people you have in your country and the number of pharmacists you have in your country. To a certain extent, it's not as direct as we might think, but to a certain extent, if you've got lots of population, you tend to have more pharmacists. However, when you look at the number of pharmacists per capita, so you standardize your pharmacist population per country, you can see we have a huge variance, a huge variation in pharmacy numbers. So we've got countries on the left-hand side with lots of pharmacists per capita, and we've got countries on the right-hand side with small amounts of pharmacists per capita. And that's an astonishing graph, that. Just look at that variation between one side and the other side. You can't maybe see it very well on the screen here. Anyone hazard a guess as to the country with the highest density of pharmacists in the world? Any ideas? Anyone from Malta here today? Well, that's a surprise, since it is the country with the highest number of pharmacists in the world. And that's the sort of spread that we're looking at. So Malta, for instance, 2,500 pharmacists for every million population, all the way down to Somalia, which has the lowest density of pharmacists. 2 pharmacists, we think, per million population. And that's an astonishing variance in numbers there. Astonishing. If we look at the number of universities or faculties of pharmacy as well, you also see a great variation. Over on the right there, we have India, Brazil, and America, USA. I couldn't fit them on the scale here, because they've got so many, so they're excluded for the time being because they have lots and lots. India, we think, has over 1,000 faculties of pharmacy. We think. We're still not quite sure, astonishingly. But you can see, again, a huge variation. But it's not quite as you may seem. Let me just give you an example. That country there is China. And you can see it's, if you just count the numbers of schools of pharmacy, there's quite a lot there. But if you then standardize it to population size, so how many schools of pharmacy per population, China gets to the other end of the spectrum. So although a country may have lots of schools of pharmacy, it's about the standardization with population size which really matters here. But there's still a massive variation throughout the world. And let me just go back there. I have to say, this data is already out of date because the numbers of schools of pharmacy are growing almost week by week. In many countries now, pharmacy schools are seen as a commercial advantage to universities. They're very popular. Pharmacy courses are very popular. Universities are opening up new schools of pharmacy all the time, and that might be a particular challenge for us. If we are to look at the ratio between pharmacists and graduates, so the horizontal line here is how many students, pharmacy students there are, and the vertical line is how many pharmacists there are, you can see there's a sort of linear relationship. What you can't see very well, these are European countries I picked out just for this chart. So a lot of European countries. There you can see Malta, right at the top there. Down here, in this box, all the African nations can be fitted into that box there. That's the difference we have with the lack of capacity and resource in Africa compared to Europe, for example. And it's a very acute challenge for us. There's just some comparisons about supply and capacity for you. Now, here's an interesting thing. How many female pharmacists, how many male pharmacists there are? And how many female undergraduates, how many male undergraduates? I'm looking around the audience here, and I can only see one or two men. There's someone here. Sir, you've got a beard and a mustache. I'm guessing you're a male. Okay? You're sitting next to the only other boy I can see in the audience here. There's only two of you from what I can see. No, there's some more over here I can see. But the majority of you are female now. Majority of female. And although we have variation across countries here, the important chart I want to show you is this one, which compares the number of female undergraduates per WHO region with the number of female pharmacists. And the blue bars are undergraduates, the green bars are pharmacists, and in most regions, these are aggregated data, so we've added countries together into regions, the blue bars are getting much bigger than the green bars, which means that as time goes on, year by year, there are more female pharmacists than male pharmacists. The gap between the two at the moment is about 5%. That's growing year by year. So throughout the world, we're seeing a trend towards more females entering the profession. And if you think back to my first diagram that I showed you, lots of females, quite naturally, quite normally, will be wanting to take career breaks, to have children, raise families, so they'll be coming out of the workforce. So we have to start to think of ways of more flexible working, more flexible employment, but above all else, more flexible ways of maintaining continued education. As people come out of the workforce for a few years, they will want to come back into the workforce. So retraining, re-education is going to become a big issue for many nations and for many professional and educational bodies. There is an economic factor in all of this. The vertical axis here is the wealth of a nation, measured by GNI, so that's income, so that's how wealthy nations are. The horizontal axis is how much is being spent on healthcare, the proportion of national wealth spent on healthcare, and the size of the dots is how many pharmacists they have in each country. So you can see that the wealthier nations spending more on healthcare have got bigger circles, more pharmacists, compared to down here. Look at all these small dots down here. Poor countries, low spending on health, not many pharmacists. And that, to me, sort of typifies these complex relationships. We cannot have global equality. Patients cannot have global equality unless we get this capacity issue sorted out. In my view, every patient in every country should have access to medicine's expertise, should have access to the same level of medicine's expertise, which means that really we should be focusing down here and not necessarily focusing up here. That's my personal view. And this sort of shows you why that should be the case. These are high-income countries, so these are wealthy nations here. These are poor nations down here. And you can see that the number of pharmacists, that's the blue dot, compared to the number of pharmacies, gets bigger. So these wealthy nations here have many more pharmacists than pharmacies, which means that pharmacists are doing other types of work, and that is mainly clinical pharmacy. They're working in hospitals, they're working in clinics, they're working with GPs, and they're doing much more clinical pharmacy here than what's going on down here. And here you can see we have, on average, we have more pharmacies than we have pharmacists. So who's running the pharmacies? Because certainly they're not pharmacists running them. So we have a problem with regulation and control of drugs, I think, down here, in addition to the capacity issues. And finally, how much is it costing you to be a student? How much are you paying, whether through a student loan, through your own money or borrowing money? How much is it costing you, and how much is it costing taxpayers, the public? This is limited data, but I thought I'd show you anyway. These are tuition fees and capitation fees going up here, and it's just on a relative scale. I haven't put actual dollars up there. It's a Z-score scale against countries down here. So we have some countries down here where going to university is inexpensive, and we have countries up here where going to university is very expensive. So it's of no surprise, I think, to my colleagues at the front that the USA is the most expensive, with Singapore, New Zealand, Switzerland. Where's Great Britain? Great Britain is just there. Canada, just there. Australia. And down here, some European, that's China, Taiwan here, Croatia, Czech Republic, Kenya. So again, a real variance throughout the world as to the costs of education, the costs to students. And maybe from an IPSF point of view, I'll throw that one out to you, thinking it might be something to look at, I think. Okay, let's move on, because time is limited, and let's take a pause there, because that's the global situation with capacity, pharmacy production. We know for sure, and I think we'll be focusing on this very soon with FIP, but we know for sure that in some countries we are producing more pharmacists than we actually need. So we are beginning to see unemployment in pharmacists, particularly young pharmacists. They're the ones who can't get jobs in many countries. A lot of European countries beginning to see unemployment in pharmacy. I know Australia is struggling with this situation at the moment. So it could become a real acute issue for young people, for students, because the guarantee of a job as a pharmacist may not be there anymore in some countries. Let's now have a look at a deeper level, if you like, about things that are driving education needs for the workforce. And this diagram here I've shown many times before, but it does summarize very well all the things which are driving workforce development. So when I now start to talk about workforce development, what I mean by that is CPD, continuing professional development, continuing education, lifelong learning. The general phrase for that, which is being used, is called workforce development now. Okay, so that's the new sort of language which is being used in many ministries. So workforce development is being driven by finance and economics. How much is it costing to deliver health services to your populations? Okay, many countries are struggling with that right now. Many developed nations are struggling with that. Many undeveloped nations are struggling with that. There is this huge thing here about the demographic. In virtually all countries in the world, people are living longer. They're living longer with more diseases. They're living longer with more diseases, with more medicines. Okay? So the demographic trend is that people are taking many more medicines now because they've got many more diseases living into old age. I'm probably the oldest person in this room, I'm guessing, but I remember back when HIV and AIDS was an acute challenge for us. Okay? It was emerging in let's say in the mid-80s, for example. Mid-80s to mid-90s, late 90s, a struggle to get new drugs for HIV control. the deaths, the mortality rates. It was an acute problem. No longer. No longer. I now have wards, hospital wards, full of old people with HIV. People are living into old age with HIV. And of course, they haven't just got HIV disease, they've got diabetes as well now, and cancers as well, and cardiac problems as well, and respiratory diseases as well. HIV with multiple diseases. And the list of drugs they're taking is huge. Cancer is a long-term condition now. People are living years and years and years with cancer as a long-term disease. So the patients you are seeing, the patients you will see as young pharmacists, are taking many more medicines than the patients I used to see when I was your age. Many more. And that's a big, huge issue, because your competencies for early careers as young pharmacists, your competencies are much more complex now, because you'll be seeing more complex patients early on. And I know that Andrea and Catherine and others will be talking more about that later. So I won't dwell on this much more. This is all driving us now towards better, more effective ways of developing the workforce. And for sure, every government that we have spoken to at FIP, every government we've spoken to about education, or WHO included as well, have said that the healthcare workforce, and that includes doctors, midwives, and nurses, okay? So us, pharmacists, doctors, nurses, we all need to have a more flexible workforce now, because you will not be in the same job for the rest of your life. Things will change much more rapidly. Your education needs will change. Your skills and capabilities will change. So without a doubt, more flexible. And it has to be competence-based. Patient safety is paramount. Competence of the workforce is paramount. Every single government is obsessed with patient safety and the competence of the workforce. And who's responsible? I'm going to ask you this question. Who's responsible for the competence of the pharmacy workforce? Is it going to be your employers? Is it your governments, your ministries of health? Is it your regulators? Who is actually responsible for the competency of the pharmacy workforce? It's actually a pretty tough question to answer that. An easy answer would be, you are, each and every one of you individually. And that, ladies and gentlemen, is an educational issue. It's absolutely an educational issue. Because at the core of health service delivery now, the core, the very heart of what we're doing for the quality, the innovation, the effectiveness, and the delivery of healthcare services, pharmaceutical care services, right in the middle of it is education. Without that, there is no competence. Without competence, there's no delivery. There's errors, there are patient safety issues, there is a reduction of healthcare quality. So this is a really big issue for us now in the year 2014. So, these are key words for you as individuals: being adaptable, being able to change, being flexible, and for you as individuals being able to demonstrate, whether to your regulator, to your ministries, to your employer, and to your patients, you will now need to demonstrate actively to them that you are competent. Okay? There's no hiding from this anymore. You will not get jobs unless you are proven to be competent in your jobs. Unless you are good at what you do, you won't get a job. That's kind of like the bottom line, I think, now. Patients demand it and expect it. Patients want to go and see a pharmacist. They expect the very best high-quality pharmaceutical care. Nothing else. Why should they expect anything else? Patients don't go and see a doctor and think, well, I'll go and see a second-class doctor. They don't say that. They will say, I want to go and see the best. I want to go and see the specialist. They say the same thing about pharmacy as well. I want the pharmacist to be the best. Absolutely. You've all got to be the best. That's what our societies now expect. So you can see the picture that's starting to build up here. How do you do that? How do you get to be the best? How do you become the best clinical practitioner? How do you prove that? How do you demonstrate that? What do you do in order to achieve that? And that is the very essence of workforce development that we're faced with. So this afternoon, when Andrea and Catherine and Ralph, are you talking this afternoon, Ralph, I think? You're talking about these new services. It's all going to be about how you do that and what tools and mechanisms you need. Okay? Let me move on. So, workforce development is all about educational progression. New ways of developing CPD, new ways of delivering CPD, new ways of implementing CPD. It's all new. Oh, we've got no sound.
Career pathway. I don't really know where I'm going and what's the right way for me to format my life in terms of as a pharmacist of the future. So I feel like I would really benefit from someone helping me and showing me the way and the path to move forward and progress and develop my skills and competence as a pharmacist.
So that was a pre-registration student about to qualify as a pharmacist, and what she's saying is, I don't really know where I'm going. I don't know what my support is. I don't know where to go in my career. I don't feel very prepared, actually, for what's coming up. And that's going to be another theme this afternoon that we'll be talking about. How do you get prepared for these early careers? She had a good education in terms of the university and internship, but she's unprepared. She's not ready for her first years. Where's my support, is what she's saying. Now, there are ways of doing this, ways of changing our support structures within nations so that this becomes more effective and easier for young pharmacists to address. And certainly if we started to have a focus on outcomes now, what can you do, what are you able to do with your knowledge, rather than just how much do you know, then that will be a step forward. So this is why competence and competency and performance have become key words for workforce development. It's not just enough about what you know. You're very, very smart people in this room, okay? You're the smartest students in the university system, without a doubt. You know so much more than doctors do, so much more. So a bigger range of things than anybody else. You really do know an awful lot. But how much can you do? Now, as young practitioners, of course, probably not very much because you're young. You don't have the experience. Time is a factor in all of this. Older, more experienced practitioners can do more. Of course they can. Of course they can. But you, how do we help and support you to get experiences doing things in a safe way, in a structured way, in a supported way? So this metaphor of the competency iceberg, I think, is really good. I love this metaphor because, you know, the thing about icebergs, you only see the sort of top bit poking out of the sea. Well, that's the bit that patients see. That's the bit that governments see. They see you just doing things really well every day. Patients come to see you and they expect you to be, every day, they expect you to be good at what you do. Every day. That's what they expect. It's a reasonable expectation. That's why you chose to do a healthcare pharmacy. What patients don't see, what governments don't see, is all the stuff that's underneath. All the stuff you have to do in order to be good. All the skills, that knowledge, all those attributes, those values that you have, those behaviors that you have, you've got to work on those every day. That's what people don't see. This is what we're talking about in this room together because we understand what that means for us as pharmacists. So how do we get there? How do we work on all that bit of the iceberg that's underneath the sea? Well, it's impossible for me to do any presentation without mentioning Miller's pyramid. I'm addicted to Miller's pyramid. And our problem with Miller's pyramid is that we tend to stick at the bottom. We tend to stick with knowing stuff and knowing how to do stuff. What we need to do with education and workforce development in particular is to move it up into this domain, where we start to do education which is about doing and knowing how to do things. Okay? That's where professional education should be pointing now. Because that's what's most relevant to you. You want help with doing things and being better at doing things in your clinical jobs from day to day. And the use of things like developmental frameworks, of which more later this afternoon, is really important. These have been shown to work. Many countries are using them, including now, of course, we have an FIP framework, which we'll talk about this afternoon. But many countries, Ireland, Australia, New Zealand, many more I can tell you about, are starting to use these support tools, particularly for young pharmacists, what we call foundation years, foundation training pharmacists. And the evidence for using them is now beyond question. You know, let's stop worrying about the evidence. Let's accept it that we've done it. We've been doing this now for over 10 years. We know they work. Let's now move on and think about how we can use them more effectively. And there are good examples now, and this is my example from where I live in England, linked up with regional structures, linked all the way up to global structures. The same structures, locally, all the way through to globally. The same developmental frameworks, and the same is true of other countries as well, and most recently with WHO. And I'm hoping that Dr. Bruno will be telling us a little bit more about how interested WHO are in you. The World Health Organization are very, very interested in pharmacists at the moment. Very interested, because they see you as solutions to many of the global problems we have with healthcare delivery. Access to medicines, medicines expertise, key. Your generation will be key to that. So we'll hopefully hear a little bit more about these exciting projects from WHO later on. So moving on with your careers, what is the sort of career journey that we would be expecting for you? There's a lot of stuff you will have to do yourself. So a lot is about self-direction, self-awareness, and ways of, ways of interacting with that. Support structures, we'll hear about more later. National career pathways. Surprisingly, very few countries have career development pathways established. Some are really good. We'll hear about one example this afternoon about career development pathways, but some countries are a little bit behind developing these right now. And most importantly, because this is a motivating factor, is professional recognition schemes. In some areas of the world, this is called credentialing. I think in FIP, we're sort of preferring to use the term professional recognition if we can. But again, this is a really important policy structure for us, and we'll be hearing more examples about that later this afternoon. Because the idea is to take you on a journey. Your careers need to be on a journey. From on the bottom left there, your very first day as a pharmacist. Very first day. What's it feel like on that very first day? You know, it's a bit of a scary, fearful experience, actually. But where do you go from that day one? Well, you can improve your scope of practice. You can narrow your scope of practice towards specialism. And, of course, you can improve your experiences and competences along the horizontal pathway, along the horizontal axis there. And in real life, there are ways of helping people to do that. This is some experiments we were doing with pharmacists in the UK. You can see various cohorts along the bottom there. We provided them with ways, professional recognition models, ways of recognizing their levels of skills and experience. And we looked at what happened to them in broad terms. And we found that the more we use these things, as they moved across, the better in place, activated themselves to do better. It's a really important key element, which is why we've got some focus on it.
My name is Ed Femish. My education frameworks gave me an opportunity to look at what
Pharmacist and a clinical director, and what he was saying is back when he was younger, using these mechanisms and tools really helped him to develop his skills much quicker and accelerated development, in other words. Okay? And that's the key feature. So, pre-service, initial education, about where you are now, most of you in this room, and then moving into early careers. You know, the first, let's say, the first 1,000 foundation structure in place there, I think is key. I'm obsessed with foundation training at the moment. I think we should put more and more resource into year 1, year 2, year 3 pharmacists, early careers, really, really, really important. Our medical colleagues, your doctor friends, when they go through their medical careers, and training for young doctors. Why don't we do that for our young pharmacists enough? You know, we really should do. And again, I'm hoping we'll hear some examples of how that can happen later this afternoon. And then, of course, as you get older and more experienced, we move into these advanced stages of careers. Maybe the bulk of the profession, most of the workforce, most of the pharmacists in any one country are probably located in advanced one. So experts, really, you know, established pharmacists doing a good job. Every day they do a great job for a lot of patients, a lot of expertise. That's where most of the professional, maybe quite a number, a fair proportion are perhaps a little bit further up. And maybe a smaller percentage up there are absolute experts, those people who make it all the way through, they're motivated to do it, exceptional people, exceptional pharmacists. And I think we need more of those, we really do. I'm hoping that more of you will become more of those people because they anchor the profession. They provide a real benchmark about the intense knowledge about medicines and drugs that we need in healthcare systems now. And I think most countries have got that sort of staging of the pharmacy workforce. Okay? That may not be fully recognized in some countries, but for those countries who are doing credentialing, for those countries who are doing professional recognition, it's now possible to differentiate and to identify these career stages as we move through. So more of that this afternoon, I hope. Here's one example that we'll hear about, but that's for later. So as we come to the end now, what are we talking about? If we're thinking about general messages and general ideas for you to take away, is that we do have to support complex skills now. The skills you need for pharmaceutical care, clinical practice are very complex. And we need to identify how you can acquire these, because you can't acquire all of them at university. It is not possible, just not possible. The university is the start of acquisition. It's not the end of acquisition. We need to make sure that in this complex world of patients with multiple diseases, taking multiple medicines, living into old age, that they are safe, that all the medicines they're taking together are safe, and that someone competent, i.e. you, are looking after them. Okay? That's the goal. So it's consistent quality in the workplace we're looking for. It's what governments are looking for. It's what employers are looking for. Above all else, it's what patients are looking for. We do have a sort of vision within FIP about how we can match local needs, local healthcare needs, with global connectivity, because I do believe that pharmacy is now globalized and will increasingly become globalized. What we can do at global level with organizations like this, FIP, the universities now working together much more coherently in a global sense, working together globally can have real benefits filtering down locally. Okay? And we firmly believe that. So I think we should try our best to connect these together. I tell you what I want, this is my vision here. I want a pharmacist in England to be able to go to Zambia and to be able to deliver the same level of care. I want a pharmacist in Zambia to be able to go to Portugal and deliver the same level of care. I want a pharmacist in Portugal to go to the USA and deliver the same standard of care. I want that global harmonization. And I think that's what patients want. Why should a patient in Zambia not expect the same pharmaceutical care as a patient in London? Okay? That's the vision. That's what we should work towards. And other people are thinking this as well. WHO, World Bank, for example, who are funding a lot of development, capacity building in medicine and pharmacy and nursing worldwide. But, and this is the big but now, these organizations are not saying, here's the money, you can have it for free. What they're starting to say now is, what is the performance of your workforce? So you say you want more pharmacists, what are they actually doing? What's their impact on healthcare? You say you want more doctors in your country, what impact are they having? Have you measured the impact on healthcare? And that is a fundamental question for all of us in this room, including our leaders, our educational leaders at the front here, including FIP, including the IPSF, is have we really measured the impact of pharmacy? You've all got individual stories about saving lives, helping patients, prolonging lives, improving quality of lives, but collectively as a nation, as a global workforce, have we measured performance? And it's a key question for us now. So this might be my last, no, it's nearly my last slide. Here we go. The key things we should be working on, I think now, this is the top jobs worldwide for us, okay? Top jobs. 1, professional recognition schemes. Love them. Fantastic. They motivate the workforce, they move us on, they improve care. No doubt about it. So this afternoon will be very exciting for you to see how that's happening. Development processes, so structures in place so that as an individual, as a young person, I know I'm starting here, I'm going to go there, 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 and there. So having that journey mapped out, top job. We need to do that in every country, okay? That means that universities, employers, professional leadership bodies, even, dare I say it, governments need to work together now. Let's just take the governments out of it just for a minute. Universities, employers, professional leadership organizations. By professional leadership organizations, I mean you, people. You're a professional leadership organization. I mean national societies. I mean FIP. That's what I mean. And we really do now need to find new ways of partnership, because no single sector can solve these problems. It won't be just the universities solving these problems. It won't be just the healthcare systems. It won't be just the governments. It'll have to be all of us working together. Fortunately, we've got 2 esteemed leaders from universities with us today who are doing exactly that, trying to find ways of linking up higher education with service development, with leadership development. So we've got some really good ideas coming later on today for you. And here are my mottos, and I give you these mottos for free. I might have mentioned them last year, actually, but I'm giving them to you again. There's no charge for using these mottos, okay? I'm giving them free to IPSF. Better training, better care, okay? No charge. And don't forget that education saves lives. Not just doing the job on the ground, okay, but educating well, educating in a structured way saves lives. And it's all about that, really.
Hi, my name is Catherine Higginson and I'm a pre-reg student, and I think in order to help develop my career I need some structures in my early development in order to help me progress and to become a better pharmacist.
So that's perfect. All she wants to be is the best pharmacist she can be. That's her mission. That's her aim. I just want to be the best pharmacist I can be. So it's down to us now, the rest of us, to help her achieve that. Right, I'm finished. I'll leave it there. Thank you all very much indeed. So I think it's my job now to invite Professor Ralph Altier from Colorado to come and address you. Ralph is one of my heroes, a fantastic leader, works a lot with FIP leading up on the academic section, a super dean of the School of Pharmacy. So Ralph, lovely to see you.
Well, good morning, everyone. It's a pleasure to be here. I express my appreciation to the organizing committee for inviting me again this year to present to this World Congress. And I'd also like to offer my congratulations to the leadership of IPSF and all of you for being here to celebrate 60 years of IPSF World Congresses. A great achievement, and I'm glad to see all of you here maintaining the high quality level of these World Congresses. So congratulations to you. So Professor Bates gave a very articulate presentation of sort of the overview and global picture of pharmacy and continuing professional development and the role of education. I'm going to talk a little bit more about the nitty-gritty of education within the university system and preparing graduates for entering practice and having the competencies, the skills, the knowledge, the attitudes for entering into clinical pharmacy practice. So I was asked to speak about the role of pharmacists in the active role of pharmacists in multidisciplinary healthcare teams. We know that the concept of team-based care is the one that is gaining momentum and moving forward worldwide. And I decided, since I was going to be talking to the IPSF Congress, it would be good to talk about the role of student pharmacists as active members of multidisciplinary healthcare teams, and by extension, pharmacists working in the same environment. So, again, as Dr. Bates mentioned, I'm the dean at the University of Colorado School of Pharmacy, also president of the FIP Academic Pharmacy section. And I'm here basically representing both. So a little bit of an outline of what I'll be talking about, a little background to set the stage for what will come in the middle portion of the talk, which will be the role of student pharmacists on healthcare teams in various settings in the practice of pharmacy. And then if we have enough time, I wasn't sure what the venue looked like, but I think we can pull this off here, is I'd like to hear a little bit from your experiences and your perspectives on some of the things that we're talking about today. So we'll see if we can pull that off near the end. So a little background, I'm going to use the example of our university. It's not unique, certainly not in the U.S. in terms of some of the things that I'll be talking about. But it's the one I'm most familiar with, and I think by extension we can say the same is occurring at other universities. So we have in the U.S. The standard degree is now the Doctor of Pharmacy degree, as I'm sure many of you know. At our school, it's 3 years of minimum prerequisite coursework at the college or university level, although probably about 85% of our entering students already have a baccalaureate degree. It's a 4-year curriculum. It has a lot of integrated coursework of integrating science with clinical aspects of the program. And the one that I'm going to be concentrating on most is the experiential learning component, which occurs throughout the program from the very first semester until just prior to graduation. And then, of course, the students earn the PharmD degree. So this is an overview of the experiential component of the curriculum. Now, this occurs because in the U.S., our accrediting agency requires experiential learning throughout the program. This was not the case 10 or 15 years ago, but it is today. So what you have are two programs. The first, roughly 3 years of the curriculum, the Introductory Pharmacy Practice Experience, or the IPPE, which we call IPPE. And then in the last year, the Advanced Pharmacy Practice Experience, or the APPE. And you can see on the slide the sort of that orange-yellow color are all the introductory pharmacy practice experiences in the first 3 years of the program, and in the green, the rotation blocks in our program. They're 6 weeks long throughout the last year of the curriculum. And they occur in various settings where pharmacy is practiced: community health systems, medical provider offices, ambulatory care clinics, and so on. And we'll touch on some of these, but not all of those. One of the goals in our program, and true with other programs as well, is that our students should never be looked upon as a burden to the experiential site. They should be adding value and benefit to that site. So it's incumbent on us to train the students and educate them to the point where they could actually do that. And of course, if they're of value to the experiential site, then they're of value to the patients that they serve, and they're improving health care. And in order to do this, the student has to be an active member of that healthcare team. They're not passively watching what's going on. They're participating in it, and they're providing health care. And so we'll talk about some of those examples of how that goes on. So just by way of comparison, Colorado is that red box there. It's roughly a square state that's got a little elongated east to west there. It's about 270,000 kilometers in size, of the population of only about 5 million people. For those of us who've been in Colorado for the past 20-something years, that's double the population that we had about 20 years ago. So by comparison, Portugal is about 1/3 the size, with about twice as many people. And we're a little bit bigger than the UK and a little bit smaller than Italy in terms of land mass, but you can see our population is only about 1/10 of those countries. So we are, in essence, a very rural state. And as a public university, it's our obligation to serve the entire state. And so you'll see here, if you see where Denver is, sort of in the upper right quadrant there, that's a big metropolitan area where the bulk of the population lives. And so we do a lot of our education, our experiential education, in that metropolitan area. But All of the red dots you see around there are the outlying areas, the rural areas in which we have experiential education sites throughout the state, as well as the schools of dental medicine and medicine. And in some cases, we have interprofessional education going on at these sites as well. So that's sort of the playing field that we have in our program. So I'm going to talk about students having an active role in interprofessional healthcare teams. But we need to have a little bit more of a definition of what that means. It's not a static definition. It's not just one size fits all. So in some cases, that team is co-located and integrated together. Typical example would be a hospital setting, inpatient care, or in a number of ambulatory care clinics. That's very easy to see of the healthcare integrated team. In some cases, they may be separate from each other, but closely associated. So pharmacies and pharmacists working in pharmacies with collaborating with clinics, with other medical providers. They may be separate in distance. It could be through telehealth, for example. And when we talk about an interprofessional team, it's any two different professions together. And it's not necessarily medicine and pharmacy, but it could be nursing and pharmacy. I'll give an example of that as well. So it's multiple ways of thinking about the interprofessional healthcare team. So I'm going to start with some of these early pharmacy practice experiences, and then I'll move on to the advanced ones. And I'm only going to talk about 3 examples here. Immunization program, non-pharmacist provider experiences where our students work, and then elective practice experiences. So we've had an immunization program for over 10 years now where all of our first-year students are certified in giving immunizations. This is all done under collaborative agreements with physicians, and since we've started our program, our students have immunized over 90,000 people. And we sponsor some of our own flu vaccine clinics, for example, or in pharmacies where it's just walk-in vaccination programs. And our student organizations are also very involved in this, and they set up health fairs and flu shot clinics and so forth to deliver these vaccinations. This is the average number of immunizations each one of our students provides. You can see on the far left here in 2007, it was up around 130 per student. And that dropped kind of dramatically over the next couple of years. And that's because we had a training program, and this sort of speaks to what Professor Bates was talking about. We ran immunization training programs for practicing pharmacists, and then their employers took it up and had their pharmacists doing most of the immunization. So our student participation fell off, but it's working back up again, and now we're at about 65 immunizations per student. And we have 160 students, roughly speaking, per class. So quite a few. Now, another program that we started also, I think it was 12 years ago now, and I think at the time it was a unique program. I'm not sure if it's quite as unique anymore, but it's been a very successful program. And this is where a third-year student, who by this time has had most of their knowledge education in pharmacotherapeutics and all the other areas, and has had, 5 semesters of experiences. The students are placed in a non-pharmacy environment, in this case usually an office or a clinic with physicians and or nurse practitioners. Students visit it roughly 32 hours in the course of a semester. And the students are working in that environment. They're first of all learning what the other side faces on a daily basis in their patient care activities. And the other thing, as you'll see, is it's really helped to enlighten the other provider community as to the value of pharmacy and what pharmacy students can do. So what the students do in their direct patient care roles in these offices and clinics: take medical histories, including doing medication reconciliation, They attend patient assessment with the provider, so they're learning about the diagnosis and what the disease states are. They collaboratively work with the physician or the nurse practitioner to design a drug regimen if that's necessary for the patient. And then they provide patient education on the disease, the treatment plan, and certainly on their medication. So a very active, hands-on role in providing health care to patients, with oversight from, of course, the practitioners on site. When we look at we weren't sure how that was going to work out in the early years. And so if you see this green line here, starting just above the number 60, so these are the new practitioners that were recruited into this program, mostly physicians. And you see that decreased during the ensuing years, because what you'll see is that most of the practitioners returned to be preceptors year after year until we were at a steady state of around 100 non-pharmacist preceptors working with our students. So they have viewed this program as being very successful, being a benefit to them and being a benefit to their patients, as well as helping to educate our students and having them perform direct patient care activities. So if we look at what our students think about this experience, first of all, they feel like they've gained a significant increased degree of confidence in their ability to provide direct patient care, having gone through this. That's the red bars versus the blue ones, the before and after picture. When you ask the student, is the provider, the physician or the nurse practitioner, invested in educating the pharmacy student, it's overwhelmingly positive. They feel that they have a genuine interest in helping to provide this education to our students and allowing them to participate fully in the health care of those patients. When you ask the students, did they get satisfaction out of their experience in these offices, and again, very high. The blue bars at the bottom is strongly agree, and then agree, and there's very little that are neutral or below that. So overall, a very positive experience on the part of our students and the practitioners in this part of our education program to teach students how to be a member of a healthcare team, multidisciplinary healthcare team, and provide patient care in collaboration with their counterparts in the other health professions. Now, we also have elective interprofessional education experiences. Many of these are done in health fairs, where you have students from the various health professions participating. And one of those, unique to my part of the world, is the National Western Stock Show, where ranchers from around the United States, and in fact from other countries of the world, descend on Denver in the month of January to show off their livestock, to sell their livestock, and to have rodeos. And it's a big blast for about 3 weeks in Denver. Well, we started, along with other health profession school on our campus, clinics at that National Western Stock Show. Many of these ranchers live in very rural areas, and they have relatively limited access to health care and healthcare professionals. So we've started running this interdisciplinary clinic where we have students from pharmacy, medicine, dentistry, nursing, providing health screenings, doing point-of-care testing, and so forth. And so you can see on the left here is your typical Western cowboy in his hat, getting a finger sticks so we can do some point-of-care testing there. And the photo on the right there is put in there specifically for Professor Bates, because he keeps thinking that since I live and work in Colorado, I should have a cowboy hat and cowboy boots on all the time. So what you see there is me in the back sitting on a Brahma bull at the National Western Stock Show. And the person who made me do it, well, that's the gentleman cowboy because I have a tie and jacket on, as you can see. The person sitting in front of me is one of my faculty members. She's the one who made me get on this bull. This bull weighs probably about 800 kilos, maybe a bit more. It's rather gigantic. You can barely fit your legs around the girth of that animal. The interesting part of the story is not the fact that I'm sitting on it, it's that the person in front of me who stands about this tall, and I think she might weigh 50 kilos, used to ride these Brahma bulls in the professional women's rodeo circuit prior to and during her pharmacy school career. Now, how a person that size, rides a bucking Brahma bull, I have no idea, but she is one tough cookie. So I don't argue with her. When she says you're getting on the bull, I'm going, yep, I'm doing it. But at any rate, this is bringing health care to people at their place. This is, and it's training students, and they're providing excellent health care services to these folks. All right, so those were some of the early pharmacy practice experiences. And then we get into the fourth year of the program, and these are advanced. This is when it's full-time clinical experiences, in our case, 6-week rotations. And we'll talk about these in various settings and what kind of results we get. So the first one is at the hospital associated with our university, multidisciplinary healthcare teams managing acutely ill patients. The students attend rounds, monitor drug regimens, provide drug information to the team. And these numbers here are based on the studies that we've done over the number of years we've been running this program. So in a 6-week rotation, this is what a student should expect to do: perform 380 chart reviews, attend 240 patient visits, make 55 interventions in drug therapy, and recommend, on this case, on average, 30 drug regimen changes to the healthcare team. And as we have learned, most of those recommendations are accepted by the healthcare team as being beneficial to the patient. So a lot of active participation and learning how to do healthcare as a student directly with patients. In another one at another local hospital, this is a medication reconciliation program. This is not the only thing the students do on this rotation, but it's part of what they do. And it's a self-directed student program where the students independently interview patients, review medication history, and recommend changes to medication regimens. And you can see there on a 6-week rotation, they'll do about 350 patients and correct 60 medication errors. Obviously a very important part of medication therapy management. So moving out of the hospital system into the community, where we also have multidisciplinary healthcare teams. This is in the Salud Family Health Center, where again you have physicians, nurses, pharmacists working for underserved patient population. We have 2 faculty members at this particular clinic who provide healthcare services, and then of course precept our students. And this is managing multiple disease states, some of them here: hypertension, dyslipidemia, diabetes being a large one also. And the pharmacists and the pharmacy students are working on their collaborative drug therapy management protocols with the physicians. And again, in a 6-week rotation, the student would review 300 patient records, work with 85 patients, and make upwards of 100 or more interventions in drug therapy. And again, most of these interventions that they make are accepted by the practicing physician or nurse practitioner. Now, this is another clinic. This is maybe very difficult to read, but I put this up here because this is a clinic that we're also involved in, but this clinic is not run by physicians. It's run by nurses. And we've joined in with our School of Nursing to provide, again, focused largely on primary care to, again, underserved patients in this clinic. Our primary preceptor here is Dr. Valdez, who's the Brahma bull rider. And she oversees a lot of the activities of our students. And again, it's many of the kinds of healthcare provision things that we've been talking about. But some of the new ones that are just being added in this year is, again, under protocols with physicians, who, by the way, are not at this clinic. They're outside this clinic, and they refer their patients to this clinic. Monitoring insulin pumps and their effectiveness, and changing drug regimens for individuals with type 2 diabetes. And another one that's very big is chronic pain management. and the problems associated with it, particularly using opioids and trying to find other effective alternative pain management regimens for patients, and also monitoring and changing the use of opioids. This is a particularly large problem in the United States and particularly large problem in Colorado. So our students are now going to be engaged in this chronic pain management activity. And then we have anticoagulation clinics. Similarly, these are student-run clinics, oversight with a preceptor, but it's the responsibility of the students to monitor these patients, make recommendations for changes in dosage regimens, and so forth. And so on average, in a 6-week rotation, a student will be making 170 of these interventions in the drug therapy. So when you look overall over 3 of these clinics and our university hospital setting, what are the students doing in terms of medication management? Well, it seems that in pretty much all the areas, whether it's the community sites or the hospital sites, they're recommending changes in dosages. And the other one that is true in most of them, except the anticoagulation clinic, is they're either starting or changing the drug regimen. And only in very few cases are they recommending discontinuation of drug therapy. Now, this is a very interesting finding because I was talking with the dean at the University of Southern California just about a week or 2 ago. And in their clinics, they find exactly the same thing. Initially, and we would have thought the same thing, initially that the primary intervention would be discontinuation of drugs because many of these people are on multiple drugs, right? But that's not true. So it's either changing doses or starting or changing the drug therapy. So it's kind of interesting, and there are plenty of data out there now, at least in our world, to show that these kinds of interventions, while they might increase the drug budget of a clinic or a hospital, they overall reduce healthcare expenditures because patients are better cared for, better monitored, and get better outcomes. So this is a rural anticoagulation student-run program as well. And the results there, bottom line, show that patients spend a lot more time in therapeutic range with the monitoring by our student pharmacists than otherwise would occur. In another disease state management program in a rural area of Colorado, this is a rather interesting one, and I think it speaks to the value and the benefit of our student pharmacists providing care, is we've set up 13 disease state management clinics around rural Colorado. We've trained pharmacists in those areas, and we provide students to them during this 4th year, primarily managing diabetes, but it could be other disease states as well. So these are all based in pharmacies with referrals from physicians to those clinics and pharmacies for care of their patients, and you can see the numbers here of the number of patients that our students serve. In one of these clinics, clinical areas, this is in Cedar Edge, Colorado, which is a small town in the western part of the state. The pharmacy is associated with a clinic, and the clinic is staffed by physicians, nurse practitioners, and physician assistants. And about a year or 2 ago, that clinic accepted having one of the student pharmacists from the pharmacy work in that clinic 1 day a week. And when one of our experiential directors went out there to meet with the folks at the clinic and find out how things were going, unbeknownst to us, we found out that it was going so well that they scarfed up the student 2 days a week. And now they're asking for a student to be there full-time. And they're taking care of their diabetes patients. And you can see some of the types of work that the students are doing. I think this speaks very eloquently to the value that the students are providing to patients, that are improving patient care, and it's recognized by our counterparts in the other health professions. So this is, you probably can't read these numbers very well, but you'll have to trust me on this one. I'll tell you what it is. And these are diabetes patients 6 months after follow-up care by student pharmacists. And all the values for hemoglobin A1C, blood pressure, cholesterol are all moving in the right direction and all statistically significant. So we have data to show that the student-provided care is at least moving patients in the right direction toward better health. The only one that's not significant on there is HDL cholesterol, which is the hardest one to change, drug regimen or not. So in summary, I would say that our student pharmacists are out there working with multidisciplinary healthcare teams, active role, direct patient care, and improving the health care of the patients that they see in a variety of settings, from hospital to community to practitioner offices and clinics. We've demonstrated that the students provide value and benefit to the experiential site and to the patients that they see, and I think this is very important for expanding the role of pharmacy and pharmacy services as we see the need for more and more participation of pharmacy in certainly primary care in these types of settings. The other thing it does is it develops practice-ready pharmacists. So when our students graduate, they're ready on day one to be an independently practitioner. But I think the other thing, and Professor Bates talked about this, and this goes to your professional development throughout your career. It also gives the students the confidence and the abilities to learn on their own and enhance their careers. Frankly, all the things that our students are doing right now, and students in many areas are doing, is really the tip of that iceberg that Professor Bates talked about. What they'll be doing in their careers, and all of you will be doing in your careers 10, 15, 20 years from now, is going to be way beyond what we see here. And these types of experiences, I think, give students that confidence and the ability to be constantly improving their services and with the new technologies that are coming out and so on and so forth, being able to provide these services to their patients. So that is pretty much the end of my presentation of how we are engaging student pharmacists and multidisciplinary healthcare teams and improving healthcare with the data to show it. We still have about 15 minutes left, and so what I'm going to ask you to do, because I want to hear back from you about some of your perspectives on these kinds of activities, and maybe what you're doing, and any other questions or comments that you may have on the kinds of programs that I just reported on. So let's take about 5 or 8 minutes, talk with your friends and neighbors, and talk about what experiences you've had that you'd like to report out on, maybe some of the experiences you would like to see, any comments or questions you may have on my presentation. So we'll give you about 5 or 8 minutes. Find the loudest speaking person in your group, because that'll be the spokesperson who will report out. Now, we obviously can't report out from everybody, but we can hear from a few of you to hear your perspectives on this as well. So you got 5 or 8 minutes. I'll let you know when time is up. Have a little chat. And by should be talking about this subject, not what's for lunch, right? Okay. 3 minutes left. Okay, you should have a group spokesperson identified, and we'll start in about a minute or less. Okay, we have about 8 minutes left to our session before the break, so I think we'll get started. Just so we don't have to worry about anybody breaking the ice to be the first to speak, here's the consequence of wearing team T-shirts to the IPSF World Congress. We'll have team T-shirt. Who's the spokesperson? Bravo. So tell us where you're from and give us, you have what, about 1 minute to report out? Gee, let's guess where you're from. It's hard to tell. So you'll have about a minute and a half to report out. You'll have to speak really loudly. I don't know if I can get this down there. Oh, there you go. Here.
There we go. All right. My name is Michael. I'm official delegate of NAPSA Australia. And we were discussing, and we kind of took a couple of jumping off points from the presentation here. But in Australia, we're moving toward pharmacists being more so primary healthcare providers. Recently, it's not moving as quickly as it is in other countries. We've just recently started up an immunization pilot in one of the states, in Queensland. It's been very well received. and both by patients, pharmacists, not as much by the medical practitioners. They're not real stoked about it. But particularly in the more isolated areas where people have difficulty getting to the doctor for their immunizations, being able to go to the pharmacy to get it has been very, very convenient for them, and they love it. Apart from that, where we'd like to see it go in the future is more of that primary health care. So maybe even identification of mental health conditions by pharmacists. Having the training there would be it would be huge, because like I assume in a lot of other countries, pharmacists are pretty much the first point of contact for people for their health concerns. Yeah. So oh, does anybody have any questions for me? None? No? I don't see anything. Thank you. Thank you very much.
So I'll make a follow-up comment on that. Is in our experience, and maybe some of you can report on this as well. He mentioned the fact that sometimes those in the medical community are not all that hot and bothered about pharmacy entering into primary care, and the role that pharmacy and pharmacists can and should be playing in primary care. What we find is that when we work one-on-one with physicians, they're more than willing to accept and embrace what pharmacy brings to the table. It's their associations that are about 20 years behind. They're a bit territorial, a bit protectionist, but the physicians on the ground that we work with really appreciate what pharmacy and pharmacists bring to the table. And in fact, you'll hear the phrase of, I need my own pharmacist. Okay, I need a pharmacist with me. So it's the grassroots level that's really important. Okay, you know, a lot of you are talking a lot, and I know there's a lot of good ideas out there. Who wants to go next? Oh, everybody wants to go next. Let's take this group right here. And then who was over there? We'll go to you next.
Good morning. So my name is Ahmed. I'm from Egypt. I want to share a personal experience. I come from a family where all my parents, my uncles are physicians. So I'm the first pharmacist in the family. So when I took this decision, I was considered like, if I'm allowed to say, a grocer in the family. So I tried to get away from the community pharmacy and try to join the clinical pharmacy, where in Egypt I work in a children's cancer hospital, where we're trying to implement a little bit the clinical pharmacy. We have direct access to all the patient profile, the labs, and all of these sorts of information we do need about the patient. The patients who are receiving chemotherapy are having many troubles that this chemotherapy ruins almost everything. So why do need in Egypt? I think that we're trying personally, every one of us is trying to do his best, but there is no general system that we have all to follow. Like everybody is trying to do, but he's doing his own effort. But like there's no general system. We're the first hospital in Egypt to do so, and we're like a role model in Egypt. But I think that we need more information to be following. Yeah, I'm 57.
So he's at a hospital that's, it's not the official name, but it's called 57357, and I had the advantage of visiting there a couple of years ago. First-rate cancer hospital for children, and pharmacy plays a huge role at that hospital. And I think that's a great demonstration of the role that pharmacy can play on the healthcare team.
Yeah, we're trying our best, but I think that there's more to do.
Yes.
Like personally, I try to talk to the patients, to the children, to assure them that everything is going to be okay. Mm-hmm. But I think that there's something missing. I think that I should know more that was missing, so I could provide better health care for those patients.
So a bit more education, a bit more career development training, as Professor Bates talked about. Yeah. Yes. Great. Any questions that we have?
Okay, thank you.
Thank you. This will be our last one. I think our time's up, and then it's break time.
Yes. My name is Tesla Vogel. I'm from Germany, but we were in an interdisciplinary group. Sorry, with a student from Japan and from Portugal and also the US, and we noticed there's a rather big difference in how pharmacies are seen, and especially the educational bodies, because in many European countries there seems much more a focus on the interdisciplinary research a pharmacist can provide, thus much more focusing towards what the chemical or industry or biotech can do, and thus less a patient focus. Also, this has to do with policies and governing laws behind the system of what a pharmacist can do here in Europe as compared to the US. So what we do definitely like about this different system in the US is this enabling of people to work. We see this in labs, but to a much lesser and direct extent focused to later professions, and so we can really learn a lot from this in the US is what we came to the conclusion.
Thank you. So, you know, he said a very good word there, which was biotechnology. And as I said, I think some of the things that I talked about and what we have pharmacy and pharmacist students doing right now is some of the entry-level work that needs to be done and is desperately needed in primary care. But I think with the advances in technology and biotechnology, the kinds of health care services that pharmacists will be providing in the future is going to expand greatly. We need to make sure in the education system that we're preparing you for that. But once you get out in your careers, we'll also have to provide, I think, the training you'll need to stay up to date as well, and you'll have to be mindful for that, because I think there is certainly explosion of these technologies that are emerging right now and will be developing more in the years ahead. So thank you very much for your participation. It was great. Enjoyed being here, and we'll be part of a panel discussion a little later this morning, and it'll be great to hear more of your comments and questions. So thanks. Is it break time? Should I just announce break time? So break time. What is it, 15 minutes, 20 minutes? What time do they have to be back? 20 minutes? You got 20 minutes. You can end the show.
Test.
Well, ladies and gentlemen, let's take our seats for the pre-lunch session. So if I could invite you to make yourselves comfortable. So, ladies and gentlemen, if I could invite you to take your seats. Lovely. Okay, so there's a little discussion group going on in the middle over there. So if you could perhaps claim your seats, because they're filling up quickly. The best seats are at the front down here. Okay, ladies, gentlemen, are we getting ready? Lovely. Keep moving down. Lovely. Good. So the discussion groups going on, could we exchange your love to each other and then sit down to reunite later on in the day, perhaps. Great, lovely. So, it's with great pleasure that we start this second section, which takes us up towards lunchtime. And we are now beginning to focus a little bit more on practice development. And we have a very distinguished speaker for you coming up who's got a long history with IPSF. So, Luis, known mainly as Bill to the rest of the world, I think. I've never quite understood why. Maybe one day we'll get to the bottom of it, but I don't know. Mr. Luis Lorenzo is an honorary lifetime member of IPSF. So he's the sort of person that you should all aspire to be lifelong members of IPSF. A very long history of student engagement, student activism, working with IPSF. In fact, our liaison goes back to the year 2001, I believe, when we developed some IPSF projects called Moving On projects, didn't we? Way back. Do you remember, where were we? What country in the world were we at that point? Egypt. It may have been in Egypt we did this, under the shadow of the pyramids. Luis came up with some fantastic ideas for moving IPSF forward. So we owe him a great debt, I think. Luis was also chair of the Young Pharmacist Group of FIP and is now continuing up his career progression and is professional secretary of the community pharmacy section for FIP. So it can't be that much longer before you're actually president of FIP, I think, Luis. Luis is one of these people who practices what he preaches, and he's been a fantastic advocate for clinical pharmacy, pharmaceutical care, ever since I've known him. And he now has a pharmacy in Lisbon, which is actually putting all of these things into practice. And you're going to be telling us about some of these experiences. So could I ask you to make a very warm welcome, please, to Bill.
Morning, everyone. Cool. First of all, it is an honor to be here today. I was remembering a few years ago when I started attending my first IPSF congresses, how it was like to be on that side. And I think it was 99 in London. And the thrill it is either to be a first-timer or to be here for a couple of years, to come and to share your experience and your expertise with others and to learn. It's difficult for me, to be honest, to know what are your expectations. You have different backgrounds, cultural backgrounds, professional backgrounds, educational backgrounds. I'll try to give you something to take back home, to reflect, to have some food for thought. And this is the agenda for the presentation. I'll give you a short introduction, and I'll try to present myself and to introduce you the concept of a pharmacist. I think it's very important, although we discuss a lot of issues, and I don't know if that's the same thing today, we still lack some basic information sometimes given in this sort of events and coming from the leadership organization, what is it like to be a pharmacist. I was challenged as well to reflect about the creation of a relationship with patients. I'm a community pharmacist and I deal with patients every day, so I'll share my experience on that regard. I'll focus on acute conditions, chronic conditions. I'll try to make some sort of sense with all the presentations that I'll be given so far and the ones I'll be given during the afternoon, and I'll just make a short sum up. So as an introduction, I need to emphasize the fact that I'm a practitioner. I don't make any sort of research. I don't work in academia. I have my own community pharmacy and I practice. What practitioners do, we collect a lot of data, we attend a lot of conferences, we learn, we read articles and try to make it practical, meaning we try to use it on a daily basis. This is mostly a personal perspective. Probably different practitioners will have different perspectives regarding what it's like to build a relationship, but this is mine. And all this presentation was based on my experience, not only as an IPSF EXCO member, participant, as a young pharmacist group chairperson, and also as a pharmacist. Again, I'll give you food for thought. In a way, I will act as a consultant. I'll get bits and pieces from different parts and try to make some sort of sense, and I'll open the discussion. Now, as I mentioned, I'm part of the International Pharmaceutical Federation. Some of you had the opportunity to attend the FIP workshop that was held with Emma Paulino, my fellow mate from the FIP board. So FIP represents more than 3 million pharmacists all over the world. It represents not only individual pharmacists, but also has a board just focusing on member organizations. This organization, FIP, has a group called the Young Pharmacists Group, which is the next step when you start thinking of moving forward with your career and you are just really excited about coming to these events and to be part of IPSF EXOs or working groups. This is the place you actually need to look for when you just move forward with your career. I'm also part of this community pharmacy section. FIP divides its action in different areas, pharmaceutical science and pharmacy practice. And within the pharmacy practice, we have groups devoting to community pharmacy, hospital pharmacy, administrative pharmacy. It have a whole range of interests that might suit your interests as a professional. So according to the FIP, and I have to remind you that FIP just celebrated 100 years back in 2012, and for that occasion, a Centennial Declaration was prepared. And this concept of pharmacist and pharmaceutical science, because FIP gathers the interest of both these branches of the profession, pharmacists and pharmaceutical scientists set responsibility and accountability for improving global health and patient health outcomes by closing the gaps in the development, distribution, and responsible use of medicines. As you can see, this declaration is very broad. We have people working in industry that, in a way, see themselves here covered. So for the sake of this presentation, I'll focus on the last part of the declaration, the responsible use of medicines, and how you can turn this into something practical, something you can use on a daily basis. So, creating a relationship, how? It's very difficult to have a standard, not only because each patient is different, all of us as individuals are different. We have different conditions to take care of, either acute or chronic diseases. We have different regulations. You can establish a different kind of relationship with your patients according to what the regulator allows you to do. You can follow a pharmaceutical care program if the regulator or allows you to do that or not, if you have direct contact with the patient or not, either in a community or in a hospital setting. First of all, and I think it's very important to all of us as individuals to understand who we are as individuals. When you have this approach, when we start establishing some sort of connection with patients, we need to know who we are. How do we communicate? And there are actually a lot of tools that can help you finding out what you prefer to use as a word, as a sentence, how you can approach others, how you can create empathy. One very interesting tool I want to talk to you about is neurolinguistic programming. It's a way of understanding how to interact with others. Mostly we want to establish empathy. It's called in LLP rapport. Either through visual, auditives, or kinesthetic techniques, you can actually communicate differently to different patients. It would be a challenge for me to cover all of these areas and to focus on LLP because I'm not an expert, but I can introduce you to this and to challenge you to look for some tools based on your own experience, what you think is important to do, because to give you a tool to communicate with patients is very difficult and complex. Not only we are different, we have different cultural experience and expectations. So the challenge right now, I know this is very important, is you should focus on this. It's a long-term process. It's something you will learn with time. Like leadership and other skills is something that people, some of them know or are born with some skills, but you can actually train them and to become a better communicator. Again, about the chronic and the acute conditions, the interaction and the relationship you establish with patients is completely different. I'll try to cover all of them as a kind of a bullet point system, so you know what are the basic things that should be followed and then to adapt to different conditions. Now, regarding acute conditions, you can either deal with patients with a prescription, without prescription. The idea is to follow this matrix called the necessity, effectiveness, and safety process. And I want just to do a short poll. How many in this room have heard or have learned something about the Granada Consensus on drug-related programs? Just raise your hands. Not that many. Okay, so that's a good start. So it might be interesting, my presentation. So it's good. I was worried about that. So I'm going to use this necessity, effectiveness, and safety system to help you guide in the establishing of this relationship with patients, either in acute or in chronic diseases. I'll focus on this later on because this system arose from the fact that we have drug-related programs, and it came from the consensus that was set a few years ago, that was set to identify this system. But I find it very useful on a daily basis to use this same approach to other conditions. Now, regarding necessity, and we're focusing on acute conditions, you know when a patient comes to you and asks for certain advice for an OTC and over-the-counter medicine, if that's appropriate or not to that patient. You need, first of all, after establishing some sort of report, and that has been done because you know all the techniques, you need to understand what are actually the needs of the patient. You can have a prescription and you can assume that the need has been covered by the prescriber, or you don't. And then you need to cover all of this. Sometimes you just need to ask for the patients what they want and then identify what they need, which is something completely different sometimes. Now, regarding effectiveness, you need to cover, while you're establishing a connection or a relationship with the patient, if the medicine that you are actually suggesting or dispensing is effective. We need to know if the dosage is correct, if the right advice has been given, and if there is any sort of information that the patient needs. Regarding prescription, and then we'll focus that a bit later, we'll check if when patients take medicines and they actually adhere to the therapy, if the expected results are being achieved. The third part, safety. We need to guarantee that the patient who are taking the medicine is taking it properly, is not causing any harmful effects. And if he does, we need to know what to do. We have a couple of examples regarding diclofenac and antibiotics, but also the system to report all of these problems. We have the pharmacovigilance system that is, in a way, the way to report all this information back to industry and to other healthcare professionals. Now, regarding chronic conditions, the process is very similar. You're going through a state of acute condition because you need to establish the report to understand the needs of the patient, to check if the activeness is being achieved or not, and if it's safe for the patient. However, you have other tools that you can use since you're going to follow up these patients. Right now, the electronic medical reports are being used in different countries. Some of them are shared with other healthcare professionals, some are not. We have the interview system as well can be used. We have the professional secrecy issues to be solved, to be dealt with. What I would like to emphasize as well, and then it will be more clear at the end of the presentation, is that regarding what your regulation allows you to do, and according to your practice setting, you can do some things and others you can't, but you can actually fight for having that done. Now, as I mentioned a while ago, in Granada a couple of years ago, a few professionals, academics and practitioners got together and they set a system to analyze the drug-related programs. It's called the Granada Consensus. They identified 3 major areas in which it is possible to identify drug-related problems: needs or necessities, effectiveness, and safety. How these things work in practice. If you have a patient that actually has a health problem and is not receiving medication that is needed, for instance, a diabetic patient is not receiving treatment, you have DRP1 and can identify that. Then, if you have a patient who also has a health problem but has a health problem as a consequence of receiving a medicine that is not needed, you have a DRP2. Why need to standardize this sort of practice? In a way, if you have these DRPs identified, you can report them and you can try to actually solve them either within your practice or with other healthcare professionals. Regarding effectiveness, if you have a patient with a health problem as a consequence of a non-quantitative ineffectiveness of a medication, for instance, a coated tablet is cut, you have a DRP3. Then you have clearly identified that although the patient needs that medicine, is taking that medicine, is not effective because of this non-quantitative ineffectiveness. Now, if you have a patient suffering from a health problem as a consequence of a quantitative ineffectiveness, for instance, regarding non-adherence, you have a DRP4. So we covered first the need of the patient to take the medicine. He's taking them, we check, he's being effective. And if everything's okay, you move forward to the next stage, that is safety. So if you have a health problem as a consequence of a non-quantitative safety problem, for instance, an allergy, we have a DRP5. And then if you have a patient suffering from a health problem as a consequence of a quantitative safety problem, we have a DRP6. So we cover with all of this system of necessity, effectiveness, and safety, all the conditions of a follow-up of the patients. Now, if we go backwards in the acute conditions, you can also cover these 3 areas as well. Now, in a way, all should make sense right now. If your practice is based on these 3 areas that you analyze and try to cope with, it does make sense, for instance, if you have an advanced practice, because you can focus on different needs of the patients. You can focus on different effectiveness. Imagine you're working in a clinical context, and in a ward, we have a senior pharmacy with more advanced practice who has more expertise to understand if a medicine is being more effective or not, and identify that problem. Same goes with professional development. It does make sense as well to have the basic competencies to achieve all of this in the right setting, but then throughout your career to have all the skills and all the training that you can actually achieve higher and do something different based on all of this. The expanding roles, you can actually expand roles in all these three conditions. It depends on what you want to focus on. Of course, you're going to say that we have pharmacists practicing in clinical settings in some countries and not on others. Okay, we take it, we know that's how things work, but based on this system, you can focus on the training on one of the areas so you can achieve something in the future. Regarding the multidisciplinary teams as well, if you understand that our role as a pharmacist is to promote this responsible use of medicines, and you need to cover all of these three dimensions, it's very clear for others that are working with us, what can you give back to them, and how can you actually be part of the team and to actively promote the patient's conditions. Sometimes, and I can say that, it was not a while ago, we do lack this structure in our head. What are we going to do? We understand that we are needed. We understand that you can give some added value to the team and added value to the patient. We don't know how to position ourselves within these multidisciplinary teams. Regarding leadership as well, is very important. As a former IPSF EXCO member, a young practitioner, now almost more senior practitioner, it's very important to understand what it is expecting from us through this matrix, and then to start developing programs so we can achieve higher in our practice. It's all about leadership, to set a goal, to set a vision. And actually, this is the right setting for you to start doing that, to exchange experience with other fellow mates from different countries, with different professionals, different professors, to know what has been done. And although you might not be doing that when you start practicing and you register as a pharmacist, at least you know what is expected from you or what you can do in the future, and try to do the path so you can get there and being active as young professionals and as professionals. Now, to sum up, and I would like to emphasize this very much because I deal with patients every day, and I would like to give you this feedback. It's very important to feel proud of being a pharmacist. FIP has been setting a program called I Am a Pharmacist, in which pharmacists from all over the world actually share their experience of dealing with patients on a daily basis. And this sense of being very proud of the profession is essential for you to achieve higher. It's also very important to have this clear. We are here to promote the responsible use of medicines. So responsible use makes a connection with patients. Medicines is what actually the cornerstone of the profession, and I can actually make this connection works. This matrix of necessity, effectiveness, and safety should be very clear in our minds. I challenge all of you to come up with something or some sort of practice that doesn't fit in this matrix. It is possible to fit most of it. All of things fit here, and you have different branches. If you have this clear in your mind and you start working on this, you're halfway there. Regarding the communication techniques I was talking about, IPSF has worked with FIP a few years ago on setting this patient counseling event guidelines and also some communication techniques. And although I think they're very important and they're very useful, that's something that should be done national-wide, even regional-wide, or even in your own practice. Each case is a case. You might find more interesting to communicate in a different way than the other. It's up to you and to adapt. But it's important to emphasize the importance of actually focus on this area. We have all this knowledge, and it can be very clear regarding the matrix, but the soft skill of communicating is paramount to achieve better results for patients. And it's very also important to understand that we need to adapt to the conditions. IPSF can be a very fruitful experience and sometimes very frustrating because you know that others are doing some things that we would like to do, but we don't. This is like a word of support. That's part of the deal. We need to know that in life it's impossible to achieve on top level of everything. But what you know right now, if you want to, is to actually have a vision of what you want from your practice and need to adapt yourself to the conditions that are given to you and to be a promoter of change. Thank you very much. You're very short on time, so I hope I was able to compensate the time. Thank you. Have the round table.
Great. That was really. So I think what I might do is offer these, offer that out for questions now for Luis. He's put forward some very practical views and some very visionary views as well. So maybe let's take a few minutes to see if you have questions for Bill before we move on to our next item. Okay, so over here, please. Thank you. One moment. Behind you.
Okay. Thank you for...
Not working.
Thank you for your talk. Could you please talk more about your day-to-day job and how you are changing that in light of these thoughts? I think we could take some very interesting things out of that.
Sorry, could you repeat that?
Could you basically talk more about your day-to-day job and how your thoughts on this are changing your job over the times? I think we can take a lot of information from this.
Yeah, okay, cool. So as a community pharmacy, actually I just changed to new facilities, and it's a new project that I have right now. There is this shift on the community pharmacy practice in Portugal. Over the last few years, there's a focus on services. The income has been reduced because of the reduced margins and price of medicines. So we just changed to new facilities and we are focusing on services. We now have 3 consultation rooms in which you can actually start doing some services. This is the background. Another piece of information. Sorry? Consultation rooms. Right now, our Guild of Pharmacies are negotiating with the government and the Ministry of Health a pack of services in which pharmacies are paid to perform some tasks. They're still being measured. But even so, and that's my own experience, we have been discussing a lot of support to diabetic patients. And so probably in the future, under this pack, will be paid for following up the conditions of diabetic patients. And you can say, well, that's good, but till then, we have to wait. What we have decided within the pharmacy was actually to anticipate change. We know that we have this coming, so our first step was hire a consultant and to set very clear guidelines regarding how we can actually deal with diabetic patients. It doesn't mean we're not giving them the right care. We just want to have something more advanced. So we have this technical consultant who's now working with us, setting all these internal guidelines. At the same time, we're also collecting a lot of information regarding our patients. We're trying to, right now, collect all the medication that is being taken by patients, so when the pack is approved, we have a background to analyze why, for instance, a certain health condition is not controlled. And at the same time, we're actually communicating with the community, with all our patients, that we're going to start working on this service. So right now, this is what you're going to do, what we are doing to cope with this new challenge regarding these new services that are going to have implemented. Again, we can't do that much regarding the negotiation with the Ministry of Health, but that is something you can do on your daily practice. So when something comes up, we are already prepared.
Hello, thank you really for this presentation. I have a question about the logistic. You are speaking of consulting, and for the logistic, you know, community pharmacy, sometimes, especially in downtowns, for example, they are small. And for consulting, for example, we were talking about diabetes, therapeutical education and consulting. You need space, you need like, for example, a room, or even so as to keep the professional secret. So how will you manage at logistic and economic this kind of place management? Thank you for this.
Regarding the economics, and I think it's very important to focus on this, we are running a business. We need to take care of the economic issues. I need to pay my staff. I need to pay my bills. That's a very broad discussion, and we can discuss, for instance, in the case in Portugal, that right now almost half of our pharmacies are bankrupt because there was not the right planning regarding business. And again, I'll focus on our particular case. It's not good, it's not bad, it's not what I know. For many years, there was not a concern regarding the economic issues of pharmacy, and you are closer of a public service, like meaning being served by the government. You have this really regulated system, and you have a lot of have income that was fixed, and then suddenly that changed. So either pharmacies were prepared to adapt to this, or they were just going bankrupt. That's what's happening right now. What you need to understand, and I would like to emphasize this again, is a vision. What you want from your community pharmacy. Of course, in order to deal with all of this, I was very lucky because I prepare in advance all these consultation rooms, in that particular case of the pharmacy, but others might not have that opportunity or that conditions. But again, it's up to you to do what you want to do in a couple of years or in a few more months. You need to prepare in advance how much money you need to allocate to have this area in your pharmacy. You need to calculate, is it worth it or not to have it? It might not be worth it. If you're a really small pharmacy, maybe your focus would be on providing other services than a consultation. You need to understand, again, that you need to adapt to different circumstances. In the future, we will all be pharmacists, but we all have different competencies according to the pharmacy that are practicing. You need to have different skills to fulfill the role that that pharmacy is providing. It's very difficult to say this when we want to do something on a short term. Take my word, I've not been here for that long, but things do take a while. For instance, to be here in IPSF with more than 700 participants is really enthusiastic because we had 300 10 years ago. We applied to get this Congress here in Porto 15 years ago, now we got it. Things do take a while, but most important, everything is to have this vision very clear. Vision is so important that during the YPG leadership session in FIP Congress this year, we have a session just focusing on leadership. How can you create a vision about your practice, about what you want, not only for yourself, but for your setting? What I can say to you is like, be patient, be clear about what you want, and everything will just sort out.
So I'm going to put Bill on the spot now and ask him a question. It says in your CV that you're 34 years old, Bill, is that correct?
That's right.
Wow, okay. So who's been your biggest inspiration? I mean, where have you drawn your inspiration and role models from during your time?
I had several. My grandfather, first of all, actually was managing the pharmacy till last year. It was 89. He was when he was 20. He had the basics. He had the basic school grade, and then decided just to work while he was studying. And he was always very clear about what he wanted from life. He wanted to have a degree. It was the only way to strive in the world. And that's actually how he kept on working during the rest of his life. He wanted to have this new, you had to have the new graduation because you had the post-grad on a sort of area. He was not working in community pharmacy, he was working on beer production as a pharmacist. And then throughout his life, he was always very clear about what he wanted. And that's something very personal. I want to share it with you. My grandfather, we were looking for this new era for the pharmacy in a very reduced place. Our old pharmacy was destroyed because there was a change on that area. The new buildings were built. And you were promised to have a pharmacy back in 2007. But unfortunately, things didn't work out because there was the economic downturn. And for many years, my grandfather always turned to me and said, I don't want to leave you with a problem in your life. I want to have this solved. So last year, again, about the economic downturn, there was an area in the surroundings of the pharmacy that was free. So we bought it, and we were very, very happy. That was April last year. I decided to take some days off because I was tired because it was a busy period of my life. And when I came back, my grandfather had a heart stroke. And then he was hospitalized, and for 1 week, he just shut down. There was no more grandfather suddenly. So I had to turn to myself and say, well, he had a goal in his life, and his last goal was actually have this new place of the pharmacy. He's done. So luckily he's now okay, he has recovered. There was a problem with medication actually. So hey, you are pharmacists. You should have noticed that, the first thing to do. But what was very clear about this importance of the vision, he was very clear about what he wanted. So it's always a big inspiration for me. Of course, there are other people, and actually one of them is here, Catherine Duggan, who I had the pleasure to work with in London, is always a reference, and I'm always interested in that, because I'm still using a lot of skills that I learned her about the dedication that she has for the profession, and the fact that she says that, it's not perfect, but it's the next step. So you can follow up later. So this idea of doing something, even if it's not perfect, that's something that's always very close to me, and I use it in my daily life. So it's a role model, because we all tend to focus, and we are pharmacists, on perfection. We want to do this, this, and that, but we only will do that when it's perfect. That's not how things work. Just do a small step, even if it's very, very small for you. On the long term, you will have a huge impact. So, do be well.
I think that's a perfect note to give Bill a round of applause.
Thank you. Have you stay?
I'm just going to set it up. Just relax over there for a while, and I'll get the panel up in just. Okay. So, just 1 second. Right, we're moving on to our last session before lunchtime, you'll be pleased to hear. But in keeping with what Professor Altier started off this morning, we might do a little bit of interaction with you now. While I get the panel together and up on the stage, we thought we would give you 5 or 10 minutes just to think about some of the issues that have been raised today, from the very macro, the very global visions, all the way down to trying to make it work in practice, and the new novel ways in which students can be involved with workforce issues. So we're just going to put a few discussion points up on the board for you now, and as before, maybe if you could have some informal groupings, discussion groupings going on, think about the points coming up, and we'll ask you for your feedback. And at the same time, ask you to generate some questions for our panel, which we will get up here as well. So it's kind of like 2 things we're going to do. Let's have a little bit of discussion about some of the issues raised. Let's also think of some tough questions for our panel as well when we get them up here. So we kind of like have a pause while you do that. It's not a break, it's working. And I'll assemble the panel up here while you get on with your discussion groups. So if I could just ask that the slide is put up on the screen. Please talk about these things with your friends. I'll be back to you in about 5 minutes or so. Okay? So over to you. Yeah, okay, good. All right, could you put the slide up for me if that's possible? Yes, we. Nearly. Yes, we're there. Okay. Perfect. All right, so some discussion points for you. Don't forget to write down some tough questions for our panel as well, and I hope that we can have a very lively debate as we go into our lunch break. All right? So, over to you for 5 minutes.
have your natural state, which is very lovely and back again.
It's very important bottle for you to take
That's
home,
fine,
you know
but when
that.
people go, oh, do you know,
I've
he
done
is
it
such a
before many times, trust me.
today, I hate him, and you hear it, it's really hurtful. Even if you've
I'll
gone
have
out
to
of your
think
way to
about checking
explain,
now, I don't
I'm
know.
under big deadlines,
Because I got a
need to be
soft-sided
just a
bag
bit
and it's
stricter.
very easy to break.
Please bear with me.
Or
it's not
the other
that
option is you have to drink it with the other people until tomorrow at 6 o'clock in the morning.
Yeah, I've got until 6 o'clock tomorrow morning
Exactly.
to make it through
It's
there.
the one who pretends to be an
And I'll bet
expert,
this guy right here could help
and then they're not.
Oh yeah.
dispose of that.
Yeah.
Yes.
Really, you I'm sure she can. You're so uncomfortable.
Nope.
Why are you doing it?
No, I'm trying to teach Andrea
Yeah,
the
I know we have
quality
to
of
have
Portuguese wines,
you know, like,
including port.
really nice.
She hasn't quite made it there yet.
You have to have all the stages.
I'm one of the
Some
odd
days you
ones
have to
that
put on
don't
more
drink
than others.
alcohol, does not like
That's
it.
different. That's
So
within-
this is
You still
what
are
I deal
recognisable.
every day at Congress is, would you like something? Would you like something?
You
When
know,
we're in reception.
And I never had a Portuguese wine until after the FIP. Oh, I shouldn't say that. I think I tried one or two before the FIP Congress in Lisbon, and then I learned to love them after when I did the tour, the Grand Tour of Portugal. It's pretty good.
Well, of course, I'm biased, but I do like a lot of Portuguese wine.
Stop learning.
It's
Stop
different
learning.
taste, but I don't drink it.
Right from the start.
You know, I taste it. I know different tastes. That's not too bad.
And then you'll
To
understand.
the light of my
I have a very
father
big
that
team, but
every
I also
time,
have
and
one of my
have-
team.
we have a holiday house,
She's
and the
extremely
friend,
amazing. But
your
God,
neighbor,
she
actually
rushes into
does his own
solutions
wine,
and she doesn't take
so we
people
have
with her, and
homemade
then there's all
wine
these
Yeah.
every year.
problems, and
That's
she's very
We
emotional
go and buy it, and
very
my
always
father
right
is
and very quick.
one of those
And
that
I have
likes
some
to
traits of that.
try it, to taste it, to
I
see
have
what's
some
the
traits
difference
of that.
between
Yeah,
it.
But then I
sure,
also
you
have
have
a
to
team
do
that
that.
is,
And I'm like,
all the
no,
others as
it
well.
tastes the same.
So I have to be
And
really careful how I
he kills
her
me every
being
time. It's like,
very special
no, but
and
try this one and try that one.
motivated,
See the
but
difference?
kind of
And I'm like,
pull her down a little bit to kind of go, do you know, you're really
It's all-
annoying
it's just
everyone
a
else?
It's absolutely remarkable what the same grape variety tastes like
yes.
from different places within the country or around the world.
Yeah.
It's fascinating.
True.
You don't have to drink a
That's
lot. You
super
just need a
difficult.
little, just a little
Like
bit.
management and
I don't mind
leadership, they're the
trying.
hardest
It's not
things.
like it's not
Hardest
against my
things. We can learn
religion
stuff
or
about
anything.
drugs.
I just
You and
really
me
don't like
do
alcohol.
clinical
Taste of
tomorrow.
alcohol.
We can
So
research. You've
I
even
sip it,
always kept
but
your research, your head
that's
going,
it, sip
why,
it a
why,
little bit,
what,
but
why? Education and
I don't-
mentoring, that's lovely. Managing people
Don't too much.
and leading. It's lifelong.
It's lifelong. It is.
Like you're saying, life
You know,
coaching.
the only
we
way
did that 8 years
really
ago.
to know the world of wine is
Very good.
active
7
learning.
years of leadership they talk about.
you know.
So you're probably, without even knowing
There's
it,
no
you're
passive
probably
learning.
No.
Yeah.
spot
I
on.
thought we could do it by
When I look
osmosis
back,
or something.
I'm different.
You know,
I'm different in
next to
reading
the
way
bottle
because
or
I-
reading
I
books.
have this because I don't have, and in a way, it's very funny because I come
Having
here
the
and
theory
I was
behind
here a couple
it.
years ago,
Yeah.
and they ask me, and
So
they
here's
are
an
really
idea.
very secure as I
You don't
was
have to
back
drink it.
then.
All you
Well,
have to
guys,
do
that's how
is
things work. And sometimes I
Smell
was
it.
focused on
smell
that
the
on
aroma.
Very
section.
difficult, isn't it? With
And
student
it's
cohorts.
absolutely
You're
remarkable
not talking to the students that you were
just from
talking
that
to 7
alone.
years ago.
Yeah.
So they, you know, it's
the
not like you're
differences
talking
that
and
you
you're
could
all
tell
moving.
from one to the other.
No.
Yeah,
So you
yeah,
don't have to,
yeah,
you
yeah.
don't have
Whenever
to
I
taste
meet
any.
you, you and
If
me
I
are at
understand your
different
issue, my
stages in our lives, so
father-in-law
we're
is
moving
true.
together.
That
Yes.
You come back and speak to
he
guys
Oh
like
my
this.
God.
He doesn't understand.
And they
why
are
you don't
further
drink
Right,
beer.
right.
It's
Because he
very
has it
difficult.
like
It
he
is
has
hard.
water.
Trees must
Yes.
have the same problem.
It's
Yeah.
very
With that.
difficult.
It's very difficult.
Especially if you've come from that culture, because you think you are them, and then you realise,
It's the same.
no, I'm not.
I live
Lovely. Thank you all very much for that. I've just had a quick run around the room, and I know that you are all of you, wildly enthusiastic about wanting to say something. Okay, I've had a number of volunteers. I've memorized all of you, all your faces, so I know who you are. I think my biggest problem might well be with the New Zealanders over here. I've forgotten. Sorry, Australia. Sorry. Easy mistake to make. Yeah, okay. So it's going to be a mixture. If you have some questions for the panel, then I'll make sure the panel answers. If you have something to say about what you've heard today, some of these issues, then we're really interested in hearing what you have to say. And again, we'll ask the panel to make some comments as well with that. So, we need some leaders now amongst you to start the discussion. All right, this is no longer about me saying things into this microphone, it's all about you saying things into the microphones we've got around the room. So who's going to kick us off? Madam over here, lovely. So when you stand up, tell us what your name is and tell us where you're from, first of all, because that's really interesting, and then we'll get stuck into it.
Hi, my name is Aya. I'm from Egypt, but I represent a group from the US, Turkey, and Tunisia, and of course Serbia. The general consensus of our group was that mostly pharmacies have become a grocery store, basically. And we were trying to figure out, like, what can we do to, like, avoid this? So one of the ideas we came up with was actually, Benjamin mentioned that in the US they have a pharmacist month. So we were thinking, like, why don't we do that on an international level and have, like, a pharmacist month where everybody would go out and do public awareness and let people know what pharmacists actually do and teach people how to ask their pharmacists. Because this is important that they... Hello. Okay. Most people don't know what a pharmacist is capable of, so this is really important that people learn how to ask their pharmacists. We also discussed that pharmacists should become, or should be given more legroom, or should be given more flexibility. We had Emina from Tunisia mention that they're not allowed to give biological tests, and this would be very useful so that patients would not misuse their antibiotics, for instance, so they know whether they or not they have, like, a bacterial infection or a viral infection. So maybe pharmacists would be given more legroom or more flexibility and be able to give biological tests. We also had somebody discuss a standardized exam for pharmacists, but it'd be a curriculum set by maybe FIP and IPSF. And it'd be like an easy exam, but just so everybody's on, like, the same level, basically. And that's all we had to say. Thank you.
That was really great. Thank you. So let's just ask our panel to respond to some of those. The question for the panel then is, how can we move away from the sort of commercialization of pharmacy into professionalization of pharmacy? Because we all know it's a bit of a problem. Could I ask each of you to name one thing you would like to see happen to help build the professional identity in community settings? Keep your answers very short, but one thing you would like to see happen. Let's start with Bill.
It's working. Now it's working. It's very important to have very clear standards and guidelines coming from professional bodies regarding what should be done, and how can we act in different situations. This is short.
Thank you, Bill. I think the biggest thing we can do to promote the role of pharmacists to patients and the public is to describe how we are their advocates for good medicines use and really publicise that really widely, using patients as our advocates. And I can share some details on that over lunch, but I think that's the key, and I think you said that earlier on. Sharing those across all of our countries would create a global message of how important pharmacists are for patients.
There we are. We had a bit of a discussion about this after my presentation, but I think that one of the areas that each one of you needs to do in your careers, now as students and then when you enter your career, is one-on-one with other healthcare professionals. And to Catherine's point, the focus has to be the care of patients and improving healthcare. It's not just promoting pharmacy because you're looked at as being self-serving, but the focus on the patient and what you bring to the table to improve healthcare, and you do it one-on-one with your counterparts in other health professions, and you'll convert them, and then the ball will roll.
I've always believed that you first have to believe that you're a professional. And so if you believe it, then you make decisions and act upon that. And unfortunately, I see many times professional decisions being made that are more in line with not being a professional. And so it's catchy if you start believing it and then others sort of follow in that path. So that's, to me, would be my recommendation.
So I have the tough job of trying to sum up. I agree with everything that it said. Also, I would say maybe confidence. We need to be more confident that we're medicines experts and we can work in a team. So building up our leadership skills as well.
Fantastic, thank you. Next. Here, and then we'll go over there, next, over there, next.
Hello, my name's Corey. I'm from the United States. And we have something in the United States, so we're trying to change our payment model for how we pay for medical services in general. And something is emerging called a accountable care organization. Basically, it's more, you get paid, you're accountable for the care of the patient, and you get paid on quality metrics and not so much on quantity, of how much quantity of care you provide. So my question for the panel is, where does a pharmacist fit into these quality-based payment models, and how do you justify using a pharmacist instead of other less expensive healthcare providers, such as physician's assistants or nurse practitioners?
Thank you. What I'll do is pass that to a non-USA member of the panel, if that's okay. Maybe just ask Catherine for a quick comment on that, because I know you've been looking at this from a European perspective, haven't you?
Isn't it? Yes, thank you, Ian. I think it's really key to follow on from what Ralph said earlier on. If we think about the patient at the centre of everything we do, we're not seeing patients taking less medicines. We're not seeing medicines problems reducing markedly. We're not seeing the number of admissions to hospitals as a result of preventable errors reducing. So we could propose, as a hypothesis, that there's never been more need to have a multidisciplinary approach to the care of patients, especially, as Ian mentioned in his presentation, we see more patients living longer with more diseases. Now, I actually think we need nurse practitioners, doctors, physician's assistants, and pharmacists for very different roles. So what we need to do is to talk about what we can contribute to that patient burden with all those medicines they're taking, and how we can do that in an effective way with evidence and with cost improvement, because no country is getting richer at the moment. If we can do that, and we have the evidence to show it, I think we make a compelling argument that we are essential and that we're not in competition with those other professionals. Indeed, when we do that, we know there is evidence that those professionals welcome us to the table. So this is about changing our language from we need a pharmacist there because we need a pharmacist there. We need a pharmacist there because the patients need us there. And here's our active contribution to that in the spirit of collaboration and not competition. So I would say language based on evidence with the patient at the centre, it makes a good professional, compelling case. We're doing a lot of work with the Royal College of Nursing and the Royal College of Physicians back in Great Britain, and they are all huge advocates. The doctors there now say they have doctors coming in at the morning shift saying, I can't go on my ward unless my pharmacist is with me. I think that's a marked change to 20 years ago, and it's not about whether they feel threatened, it's about us feeling confident that we have a right to be the advocate for patients' medicines use.
Thank you, Catherine. That's fantastic. Let's move on to more questions and discussions from you people. So, out here, behind you, our Australian contingent.
Hi, I'm Jess from Australia. We have a group question. In Australia, pharmacists must own pharmacies. It's very strict. And at the moment, the big supermarket companies are attempting to get pharmacies into the supermarkets. And among the pharmacist profession, there's a lot of contention over whether that's a good or bad thing. I was just wondering your opinion on that. So there's arguments of liability in terms of the supermarkets as well as improving accessibility. So your opinion.
That's an interesting question. So that's about, do we have to have pharmacists owning pharmacies? Is it a necessity? Let's start with Bill and then jump over to Stephen after that. Let's get a European view, perhaps.
Regarding specifically on the Portuguese case, we had pharmacists-only pharmacies back in 2006, and then the law changed. At the time, the argument was the accessibility to medicines, and also the fact that there was no logic behind the fact that a pharmacy, which actually is a business, is only owned by pharmacists. From my experience, and when I compare with other countries, it's mostly a political issue. And you can come to, the government wants to change the legislation from a pharmacist-only ownership to anyone ownership. And you come to the bottom line is that there is no fact, or you can provide some evidence regarding what has been done in other countries, but ultimately it's a political decision. And it has to do, and I'm very, very, very open about this, it has to do about the lobby, how those things work. Of course that we can try to avoid that if you focus, as Catherine mentioned, on an evidence-based approach. If you focus on what is achieved by a pharmacy, which is owned by a pharmacist when compared with others, in case that, for instance, you don't have that in your country, then you have an argument to protect the property. If not, you need to compare it with others. Ultimately, and although I believe, and that's something my personal perspective is in the Portuguese case, it's very important for the pharmacy to be owned by the pharmacist. Ultimately, with the right tools and the right standards, it is possible to have advanced practice and really good pharmaceutical care in a setting that is not owned by a pharmacist. I don't know if I was clear. It's very complex. Has to do a lot of politics. It has to do about evidence or lack of evidence. There's a lot of variables in all of this. But I always believe that it's possible to provide a good service and good pharmaceutical care as a pharmacist in any conditions. Because on the other hand, I know from my experience as well that pharmacies that are owned by pharmacists don't have the highest standards sometimes of practice. So that's not a connection between one or the other, although it's much more comfortable to have it because the communication with the owner is easier because people may understand that. So again, it's very variable. The focus should be practice, and then everything just makes more clear.
Yeah, so I'll speak from a country that has ownership of pharmacies not by pharmacists. But we do have a requirement that pharmacists have to be in there when dispensing of medications that are per prescription. To me, I think the issue comes down to access and cost. Is the current mandate limiting access for patients to get to their medications? And secondly, are you, by having this mandate, are the costs of obtaining medications more than they need to be? And if the answer to both of those or one of those is yes, then I think you need to try to provide the best access and the lowest cost to patients to be able to get needed medications. And so I think the issue is, how as pharmacists do we need to make sure patients are getting the right medications and using the best medications as priority number one, as opposed to focusing on the ownership of the actual store. But that's my personal perspective coming out of the background where I come from.
Thank you. That's really interesting. Thank you very much for your question. Very good. Let's pick up on more of your discussions and more of your questions. And I'm looking sort of back there right now. Yes, you people around there, you were talking quite a lot. None of you are making eye contact with me now, I'm noticing. One second, sir. Someone from the back here? Someone over here? You were chatting over here? No, then we'll come to the front over here, sir. Thank you very much. Sorry, I missed someone. Wait, yep, got it. Perfect, thank you. We'll come back to you in a moment, sir. Thank you.
Hello, I'm Jernej. I come from Slovenia. We're here today discussing the advancement of our profession. And obviously, all you panel members, as we have seen from your presentations, are paragons of this advancement. Now, I would like to ask you, have you ever in your career so far encountered, how should I say, resistance from your, or opposition from your perhaps more conservative colleagues? And how did you manage to overcome it? Thank you.
That's a really great question, I have to say. Fantastic question. Let's look, first of all, to Ralph, because you've shown your career, Ralph, is exemplified by leadership. So it's about how did you deal with those people who got in the way of progress, those people who said this will never work, the naysayers, the people who say, you know, let's just carry on dispensing drugs. How do you deal with people? Give us top tips, Ralph, for helping deal with difficult people.
I'm not sure I'm the person to answer this, but I'll give an answer anyway. I will give you an example of, and this actually goes back to the last question about pharmacies being owned by non-pharmacists. In the US, we have large chain pharmacies, and they're in supermarkets and other things like that. In one of those, when it came time for the immunization program, and I talked about how we were training pharmacists to do that, this chain said to their pharmacists, anybody who doesn't want to be trained in immunizations can go out and find another job because you won't work here anymore. So that's one way in the private sector to get people on board. And frankly, not all pharmacists went on board, and they had to go find work somewhere else or they were out of a job. But that's one way of provoking change. And again, the private sector usually can get away with that pretty reasonably. I think the other one is simply competition, whether you're a pharmacy owner independent or you're working as an employee in a pharmacy, is when other people are starting to provide services and they're getting all the business, you get the message pretty rapidly that if you don't change, you'll be left behind. You know, there's a saying, and I'm not, somebody here can remind me who said it, but it was, if you think you don't like change, wait until you try irrelevance. So you'll like that even less. And the fact of the matter is, I think that it's true in pharmacy as it's true in anything else in the world, that you must change and you must adapt, or you become the dead dinosaur and an oil spot, I guess. And so it takes time for that transition to take place. I think you see pharmacy is in a huge transition period around the world, and I think the adapters will survive and the others won't.
That's great. Thank you, Ralph. Catherine, you're dealing with a lot of change, national change at the moment. How do you deal with things like that?
I think what was really interesting about the question was the personal story. And here's some top tips. If you've got big ideas for big change, you need to do an awful lot of little things, and you need to do them well. And I would argue that IPSF could do some of these things for each other. The first thing is you need to go out and find your facts. The second thing is you need to gather some friends and advocates around you, not just because you're going to need them to cheer for your idea, but you're going to need their support. And when people punch you and trip you up because they don't like your idea, you need to go to them to help you along. And then you need to gather evidence as you go, and you need to listen to the people who don't want to hear the change and understand why they don't want to hear the change, and maybe adapt your argument from the this is the right thing to do to this is the right thing for you to do. And the moment you do all of those pieces with the support of your peers, you will find you can make one very small step of change. And as Bill said, if we all make one very small step of change, it ends up being a very large step of change for us professionally. Having your peers and colleagues around is absolutely essential for this, because you need to build up what we were talking about, which is resilience. So when Ralph and Stephen, Andrea, Ian and Bill have all tried to put change into practice, you will have the people who believe you and will help you, and you will have all the people, for whatever reason, don't want that change to happen. That's what we need to help each other with.
Fantastic. Let's just finish this particular conversation with Andrea. You're building leadership roles at the moment, Andrea. You're early in your careers. What's the one thing you've learned to help with changing people's minds?
Okay. I'm not sure if I'm in a leadership position for that matter, but I can have my 2 cents. I think one of the key aspects or the key thing that I can tell you is listen. Listen to what they're saying. Try to understand why they're saying. Because sometimes it's mixed communication, or you don't really understand the communication behind it. So once you identify a problem and listen to why they're saying that, it might be easier than to explain in different words or explain your idea with the different concepts. Is that? Yeah?
Thank you very much. So we have time for maybe 2 more, maybe 3 more. Over here? Over here? Lady, yes? Thank you.
Hi, I'm Acacia, representing the BPSA from UK. I have a question for the panel, really. Now, when Professor Bates pulled up that graph showing how some countries has an oversupply of with very little demand for it, and some countries has no supply of pharmacists, but an extraordinary demand for it, is there anything that we as students, the future of the profession, and some of us representing national and international organizations here, what can we do to play an active role to manage that? Thank you.
That's a huge question, okay? And I know it's a great question. It's a huge question. I know many governments who are struggling with this question at the moment. Before we hand it over to the panel, because they're going to have to think of very short things to say about a huge, big question, let me just throw it back to the audience and say, any of you have any ideas or suggestions for that? Let's hear your views, first of all. Do you want to follow up? Or the person next to you?
Personally, obviously, I feel that some of the barriers we face is, trying to control the numbers of that, because this doesn't just involve us, it involves a lot of people, as you said, universities, potentially the government as well, and policymakers, and these people that control the numbers of pharmacists, like graduates and, people who essentially become pharmacists in the workforce, So it is a very big involvement in everyone's part.
Could I just hold you there? I've just had an idea, if I may.
Yeah, no.
Because what this might boil down to is, should we in pharmacy do what our medical colleagues do? And generally speaking, they control numbers. So the intake into medicine is generally controlled. It's fixed, because that fits with national workforce modelling. In pharmacy, that is not the case. Okay, and we've seen many more universities springing up, many new different departments of pharmacy. So let me ask you this question. This is a vote question, okay? Should we control the intake of pharmacy students so that we control national workforce? Who thinks in this audience we should control the intake of pharmacy students? Interesting. Who believes in this audience we should have a free market for education? So all the academics think there should be a free market, all the students think. Why do you think that? Let's hear your views as to why you think you should control student numbers? Really interesting question.
Hello. My name is Diana Tamer. I'm from Lebanon. Well, I can tell you about Lebanon. We currently have 5 schools of pharmacy. Each one has around 400 students. And the Ministry of Education, they just signed for 6 new schools. And we just graduated. We're going to the PharmD the last year. And still, we don't think we're going to stay in Lebanon if we don't have jobs. And most of our colleagues are traveling. We have nowhere to open a community pharmacy. We have no jobs in the hospital. It's overcrowded. The market is overwhelmed with pharmacists, and we're sad. Like, we might have to leave our own country because of this. So, yes, numbers do matter for us.
Thank you. Let's collect some more views from you. So a lady at the back, and then we'll come down over here. So, yes, madam, stand up so we can see. That's perfect. Thank you. Okay, and the microphone girls, you need to run now. Okay, so running. Okay, off you go.
Okay, my name is Melanie from Germany, and I'm not for controlling the number of students, but the number of faculties. For example, in Germany we have 22 faculties of pharmacy, but there's lots of master degrees popping up for like chemistry engineers who study farm tech and go into industry, and that was kind of a branch for pharmacy students, and now they just get into it, and pharmacy students are not even allowed to enter that. So I'm just proposing that maybe controlling the quality and the numbers of faculty and not the admission numbers of students.
Thank you for those views. Very interesting. So microphone lady now, you've got to run all the way over here. Run. I mean it. Run. Faster. And then you next, madam, okay?
Hi, my name is Amy Howard. I'm from the United States. I would agree that I don't believe that we should restrict. I'm going to agree with Dr. Bates in that everyone everywhere should be able to anticipate and expect that a pharmacist can provide care universally, which I think then falls back to members of the IPSF and the FIP to help us instill standardization of capacities and competencies so that we may do that, because I was one of those people that raised my hand and would happily volunteer to go back to Africa to work there. And whereas they have saturation issues in those countries, maybe those saturation issues might not, because I saw a fair number of other people who were willing to dislocate themselves happily to other countries where the need was. So maybe if we just spread it around, because we have a more universalized standard and give us the ability to transport ourselves.
Thank you for that. So the lady just in front there, great.
Hi, my name is Jessica. I'm from the United States, and I'm on the opposite. I think it should be controlled, just because, just like the picture showed, the United States is very expensive to become a pharmacist. And I mean, you can be, when you graduate, have $100,000 in debt. And if I become a pharmacist and I have family in Miami and I want to stay in Miami, but I have no job there, how can I pay the $100,000 I just spent to become a pharmacist?
Thank you very much for that view. Welcomed. Here at the front now.
Hi, my name is Pernod Akkervan. I'm from the Netherlands. And we actually have 2 faculties of pharmacy in the Netherlands and 1 on pharmaceutical sciences. And the number of pharmacy students is actually regulated in the Netherlands, just to avoid a surplus of pharmacy students, to avoid what they have in Lebanon right now, but also to control the outfall of students, because a lot of students also, especially from medical school, if they don't get in, a large number of them wants to transfer to pharmacy, and they want to reduce the risk of people applying for pharmacy, and then when they do get accepted into medical school, leave and take away the position for people who actually want to be pharmacists.
Okay. Well, I hope the panel's listening to all of these views, because we'll be coming to you soon.
Jenna, BPSA UK. I'm kind of probably the same as all the other British ones here. Why would you spend 4, 5, 6 years doing a degree of pharmacy, going into it, and you think, I'm going to be a pharmacist, and then when you come out, you decide, or you're told that you can't be a pharmacist anymore because there's no jobs? So I'm completely for capping at the income, so that at least you're kind of more guaranteed to get a job at the end of it.
Thank you for that view. Really pertinent question. Over here on this side of the room.
I agree with both points. The main issue I see is in high-income countries that would make a lot of sense, but in low-income countries, you could control the number of students you have, but you can't control if they actually stay in the country after. So maybe after a couple of years, you won't have more than enough students. You'll have less than what you actually need, which is what I believe is happening to many countries right now, such as Africa, as we saw on the map.
Thank you. Really interesting. Back over here.
Hello, I'm Angel from the United States as well. I don't know about different countries, but in the United States, the students, as all of us, we could make a difference. In Texas, we already have 6 schools. One opened last year, and they had plans of opening another one in 2 years. But in Texas, the students were able to go to Capitol Hill and stop the proposal of opening the seventh school. So as students, you could also be involved if you don't want another school to be open, or if you want another school to be open. As students, you could go to your Congress and make a change.
Lovely. Controversy. I just love controversy. So, gentlemen here, thank you.
Hi, Ben Greathouse from the USA, and I'm against capping the number of pharmacy students because pharmacy is a rapidly growing profession. There's new branches that are opening up, and there's so many new ways to go that if we're having trouble finding jobs, that's more because we haven't expanded our profession to the point where we have the jobs. We need to keep working to expand our profession and make sure that we have enough pharmacists to take care of what we've expanded to.
Thank you for that. We will take one more question from that gentleman right over there, if you don't mind, because he had a question earlier on. Let's take this gentleman right at the back, and that will be our final question or contribution to this. Right at the back there, you need to run, quicker, faster, 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 faster. Perfect.
Yeah, g'day, I'm Brendan from New Zealand. Just in reply to being there about expanding the profession, in New Zealand we actually made a thing that we can become a prescribing pharmacist last year, so we had 14 pharmacists go through that program who can now prescribe, but they've got no scope of... There's nothing for them to do with that qualification, and so it's led on to this year there's no one in that program now, so they sort of tried to expand the profession, but there's nothing for them to do. And I think if you sort of don't cap the number of students, would that not bring the quality of our profession down? And then again, the public look at us as not very professional.
Yep, very good point, very good point. So, look, I really enjoyed that. That was good. But we've come to the end of our time. So what I'm going to ask the panel to do now, I'm going to put you on the spot. Are you in favor of student capping or not? Give me one reason why you've made your choice. Should we start? Ralph, you look very, very keen to start this one. Or shall I leave you to last? You're the senior academic amongst us.
I'm ready to go.
We'll leave you to last. Let's start with Bill.
Gonna be a bit longer. than that? Just share my experience because I've gone through both process. Just one reason? Actually, one reason, that's difficult. I don't believe that cutting the numbers of students will improve practice. Why increase competition? Some people are not tailor-made to be pharmacists and need to get out of the profession. I had the same experience as Ralph. One of my pharmacists refused to administer vaccines when he started to do that. So probably that person was not tailored to be a pharmacist, and then she had to get out of the workforce. So that's not the main reason, competition for better practice.
And just to keep the cameraman happy, Andrea.
Oh, thank you. It's so lovely. Yes, I'm against capping the numbers. Why? Think about how you're going to do that. Is it by exams? Is it by interviews? How are you going to do that? So competition is healthy, but not at that stage. All of us went to pharmacy, and all of us want to be good pharmacists. My also challenge to you is, why not focus on increasing the role of the pharmacy in the community and with parallel with governments and policies? Why don't we increase our value and have therefore more roles within the society as team members of the healthcare professionals?
Thank you. Catherine, I know you represent a professional leadership body, so just to be clear, this is a personal opinion from you, not an official position.
I bet somebody tweets it nonetheless. I actually have huge empathy for students who embark on a career and not know that they're going to have a job at the end of it. I think that is a really important consideration. That said, and when I graduated, I was almost assured I could get a job. So I really understand that. I actually think we may need more pharmacists out there than we know for all of the roles that we talk about. Extending services in hospitals to 7 days, 24/7, mirroring a same standard of care in the community. And what about all those drugs we need to find? Where are the pharmaceutical scientists and pharmacists in that community going to come from? But I don't think it's as simple as whether we continue to grow the pharmacy schools or cap the numbers. I think our academics need to work with our industrialists, and we all need to work with the healthcare teams to make the jobs happen, so you don't see students coming out and falling off a cliff, even if they're the best students we can produce. So I actually think we all need to work together to make this better. I think capping could have all sorts of repercussions, as it had in medicine 20 years ago. But I think we need to do it in a better way than is being proposed.
So I believe the competition is good and it makes us better. So obviously I'm against capping of it. But I think the question here is not whether it's a national decision or not. The real question is, how do you prepare yourself? How do you become ready for the future? And how can you prepare yourself? And actually, I'll be speaking today, the last presentation, for 50 minutes on how do you prepare yourself. So I'll leave my sort of ideas to that time frame.
Thank you, Stephen. Thank you. And Ralph, you have the last word.
So I have a quote, and I know where this one came from. You have to be a fan of professional baseball in the U.S. to know this, but there was a catcher for the New York Yankees many years ago by the name of Yogi Berra. And many quotes are attributed to him, but one of them, which I really like, is, I don't predict anything, especially the future. Think about that one. We wouldn't predict anything else other than the future, and he won't do that. How many of you in here know what pharmacy is going to look like 15 or 20 or 25 years from now? How many of you in here know what innovation you're going to bring to pharmacy and healthcare in your careers? How many of you know what opportunities are going to open up for pharmacy in the future? None of us know what the answer is. We know what the potential is, but we don't know what the answer is. And by restricting the workforce. And I can tell you this debate goes on with deans in the U.S. all the time. It's tough when you have to think that not capping it means you're going to have more and more competition. But as Dr. Eckel just mentioned, that competition keeps you sharp, it keeps you forward-looking, it keeps you on a vision for the future and better preparing our students and our graduates and practitioners for what that future is. We can see the potential, I think Catherine mentioned that, and oftentimes by restricting the number of people that enter the field, you restrict its innovation in the future. And I'm not so sure that's a good thing to do. I think it's happened in medicine. I think that they've been stuck for many years, and it may be the result that because they restricted bright people from going into the field and innovating. And I'm not so sure we should do it. I mean, there's a very strong tendency on the part of deans like myself to say we should restrict it because it's protectionism, and I'm not sure that works. I don't think it does. So,
thank you all very much for that. I know for a fact, an absolute fact, that this exact question is being discussed by governments, many governments throughout the world, about how we manage healthcare planning. Not just for pharmacists, but for doctors, for nurses, for midwives, and we are part of that. You've got to remember, ladies and gentlemen, we are the third largest profession. There's nurses, there's doctors, there's us. In terms of numbers, you know, we're pretty big, we're up there, and we are important to governments. I think this debate will continue. I'm going to ask the panel to give all you an applause for those discussions and thoughts and questions that you've asked us. So thank you very much indeed. Okay, I need to hand back over to Fami now, who is officially in charge of things.
Thank you so much, Professor Bates, and thank you so much for all the member of the panel discussions for the interesting discussion, and it's very enlightening for all of us here. And before we go for the lunch break, I want to give some sign of appreciation, small gift for the speakers that have presented their lecture in the morning session. So for Professor Bates. And also Professor Altieri. And also Dr. Lorenzo. So that ends our morning session for today. Before we go to lunch, we will have the Congress picture taken at the Faculty of Pharmacy. So the helping committee will help you to direct to the location where the photograph will be taken. And we will be back here at 2 for the afternoon session with Dr. Bruno, Dr. Dugan, and Dr. Eckel. Thank you very much. Enjoy your lunch. I apologize. We will start the afternoon session at 3. So you will have 1.5 hours for lunch. Thank you very much.
It's a 3, not a 2.
3? Wow.
Thank you very much for having us lunch.
Yeah, that was very.
It's an hour and a half, I think, because they need.
Hello. Hello, everyone. Uh, can I invite you all to be seated because we are going to start the program for the afternoon session soon. Thank you. Before we start the afternoon session, I have an announcement to make for the presenters for the member association poster competition. The evaluation process will be done during the next coffee break session, so please be ready for the evaluation. Thank you. Dear distinguished guests, dear Congress participants, welcome back to the Educational Symposium of the 60th IPSF World Congress. To start the afternoon session of the symposium, I will introduce you to the chair for the afternoon session, Dr. Andrea Bruno. Dr. Andrea Bruno is the project coordinator and researcher in the International Pharmaceutical Federation Education Initiative, a post she has held since January 2011. Her areas of responsibility in FIPAD encompass all issues relevant to communication and coordination plans for projects within the domain areas of development teams, domain vision, competency, academic and institutional capacity, quality assurance, pharmacy support workforce, social accountability, interprofessional education, continuing professional development, leadership, e-platform, and IT-based learning and global observatory. Please join me to welcome Dr. Andrea Bruno.
Hello, thank you. Good afternoon, everyone. Because we're running a little bit late, I'll try my best to skip through part of the presentation. Although it's after lunch and I know it's coffee time, so I will try to engage with you. Okay. Let me put this to work. Is not that one. Sorry. I can't see mirror displays if that's what you're asking. Double check now. Can you try again? Ah, perfect. Thank you. After this minor technical problem. Hello, I'm Andrea again. Let's start the presentation quite briefly. So a little bit of an overview of what I do. Fami presented a little bit of what I do. I'm part of the FIP Education Initiative as a project researcher and coordinator. So I'll give you a little bit why we think students are important. I'm also an IPSFer myself. So this is actually, if I think about it, maybe the 8th Congress I'm attending. My first Congress was in 2004 in Halifax. How many of you were there? Where's Carlos? So how many of you is the first time attending an IPSF Congress? Wow. Fantastic. Congratulations for coming here. So I'll talk a little bit about the IPSF, the competency concepts briefly. We'll have workshops on Tuesdays so we can break it down a little bit better. We'll talk about the global competency framework, human resources, and also all the tools that we have at FIP Ed, and how you can get involved and engage with us. So why is students important? And this is one of the things that I think it's also my words. It is vital. Again, it's a great honor to be here where I am today, and it started from that side, similar to Luís Lourenço. So we have that commonality. As you can see, we continue to do work through associations. And how many of you know this TV series? Raise your hands. Fantastic. So we'll have a little bit fun today. I'll ask you a few questions. I'll probably ask you to stand up so you don't fall asleep. Is that okay? Yes? Yeah? Louder? Thank you. So why competency and why competence? And even in English, and if you think about translating it to different languages, even in Portuguese, we have difficulties. So competence is the overarching capacity of what we do. Competences, without an I, it's about the what of practice, our task list. Competencies, which is competency, the singular, it's about the how of practice, how we actually perform in practice. And so that's why we have some competency frameworks enable to do that, or enable to help us to develop our practice. So when we say competencies, we're focusing on the content, and it's the developmental part of our practice that it's more important. If you think about what we've spoken about since morning through Professor Ian Bates, Professor Altieri, and actually Dr. Lorenzo, it's the opportunity of becoming better, of performing better, and that's what we mean by it. It's your practitioner development, your pathway, and your professional recognition that Dr. Duggan will speak a little bit more about. Ian mentioned this one. I have stolen this slide from him. I can say that officially. But it gives you an idea of what is it that we're talking about and what it's visible. So sometimes we don't see the whole picture. So competency, it's about the persistent behavior, the better performance that you do in your day-to-day practice. But behind that, you have all the knowledge that you were taught at university and self-taught as well, the skills to be able to perform that type of job or that type of area that you're working on, your abilities, but also your values, attitudes, and beliefs as a professional. So, briefly overview of what we think could be a pharmacist developmental model is about going all the way from what we mean by undergraduates, so while you're still a student, or you're an intern, or doing an internship, or pre-registration, all the way to higher level of practice. So what we mean by post-registration foundation, it was something that Ian mentioned about the global competency framework being the base for the foundation of your first years, your first 3 to 5 years of practice, where we need more help and where sometimes we feel a little bit more lost. Okay. So thinking about lifelong learning, who knows about this word, lifelong learning? Raise your hands. Who has been in contact with EPSA lifelong learning and IPSF lifelong learning? So see, some of you, so maybe a third of you, which means that you're already knowledgeable about your continuing professional development, your continuing education throughout your career, which is great because that's what will happen. And we're always learning. As I mentioned in the workshop yesterday, we were talking about what skills do we need and the continuing of learning throughout our lives. And I learn from you as you learn from me as well. So it's a engagement activity. This just shows us a little bit of from undergraduate all the way to higher level practice that we start learning from the teachers on site and with your peers all the way to when you be by yourself and you need to be self-directed and learning more from you, but also from face-to-face models, so a type of lecture or a type of workshop or a training program, all the way to learning online and long distance because you're not able to do the course or the training in the system, in the school. So, what do you think about this sentence then? Who wants to be the first one to talk? This is the engagement activity. I know there's some sleepiness, but who knows Sheldon? You're not Sheldon. Again, who knows Sheldon? Okay, yes, fantastic. So this is something that, would you vouch for this or not? Raise your hands who think Sheldon is right. No, you're not allowed to. One of you, okay, not two of you, okay, not too bad. And who thinks he's actually wrong, that we're always learning? There we go. Come on, people, raise their hands. Yes, wave them around, do some exercise. Exactly, there we go. So going back to the focus of this conversation, of this talk with you, it's about the global competency framework and how we've developed. So we've gathered about 8 educational outcomes documents, and we analyzed them. So it was across the world, across several languages as well. And we came up with this concept to help practitioners and to help our members and support our members to develop further the profession. And we have the scientific knowledge and the management knowledge, but it's all about the public health, which here at IPSF, you know a lot and you've learned a lot through CAD, through the patient council skills and events. Also pharmaceutical care, which is needed and it's focused on the patient and on medicines. Organization and management, which is something that we also need to learn, and the professional, personal side. To give you a little bit of an example of how this actually can work, this is what it looks like at the moment. So this is a type of the competency framework we have at FIP. It's just a small portion. Again, what I'm talking to is more general terms, so I'm happy to, at the discussion or further on, to explain a little bit more, but this is to provide you an idea of what we've done and what's out there that can be useful. So who likes Leonard? Raise your hands, people. Come on. Okay, so we have half. All right. Right. We still have an ongoing survey on the Global Competency Framework. It's still online. And currently we have focus on Africa, so we're getting a lot of responses from Africa to make sure that what was developed is still applicable to that culture and to that purpose in terms of area. So this is the link where you can click and find out a little bit more. The study we conducted before, we had 63 countries represented in the study. So the little green dots, which I'm not sure you can see, are actually countries, responses from countries. And from all of those areas that I just mentioned before, in terms of professional, personal, public health, pharmaceutical care, or management, we've tried to map them against the areas that practice tend to be looked at. And what we found was the least region, or consensus we mean, it's within academic and industry, and it's about organization management and pharmaceutical care. This doesn't mean that it's not relevant for them, it's just when they replied to the questionnaire, they said that they didn't do it in their current practice. So we're continuing to develop that further and investigate why is that and why we had those results. So who likes Howard? 3 only? 4 only? Okay, 5. A little bit, raise your hands, because I think this is a smaller one. Okay. Okay. So I can see that Leonard is still winning the race of the Big Bang. All right. This is an example of an assessment grid that we can add to the competency framework to help us and to support, to see our development. Again, just briefly talking about it, so you have more information if you want to after. So guidance on use, this is how the framework should be used or how we advocate for it. It's a starting point. It's a mapping tool to help us to see the development that we have. It's a guidance for early years or for our foundation years. It's also a map of outcomes, of core outcomes for that education. And also, if we use a portfolio type of a system, it helps us to develop even further. We're not saying that this is a curriculum or that it's a single curriculum. As you can see, we will give you a few examples of countries that have used the Global Competency Framework. So what they've done is they've adapted to their own reality. They did some studies about it and with the groups of experts and developed towards their educational needs and their countries. Who likes Raj? So Raj actually has more voters than Howard? Is that correct? Yeah? Okay. All right. I'm trying to see if you actually need coffee. You need coffee, so you need to reply to me with a little bit more enthusiastic. So I'll finish the presentation earlier. This is just the example of Ireland and how they took the competency framework and develop for themselves. So this was launched in Dublin last year at FIP Congress. And this is another example to the Pacific Island countries. It's a different approach to what they did in Ireland. So they focus more on the systematic approach and they focus on the pedagogical area rather than the developmental part, which is also good and different. Sorry. The Pan American region, we did a collaboration and a document that it's in Spanish and English, and resulted in a combination of several frameworks and several documents. Just to give you a view of how it looks like. So it looks slightly different, but it has the same core competencies. Who likes Penny? Come on, girls, not just the men. Well, of course, the orange delegation would like Penny, clearly. Oh, oh, fantastic, a lovely lady, right. So why we're doing this and why we're so important, and we've talked about this morning about the role of pharmacists and in the role of pharmacy in a healthcare profession and in teams. So at the third Global Human Resources for Health that happened last year in Recife, in Brazil, 2 major reports came out, and one of them is No Health Without a Workforce. And it has qualitative data on pharmacists, maybe for the first time in a WHO document that portrays pharmacists as healthcare professionals. This is some of the drivers of change for healthcare workforce, and not just us, all of our colleagues, professional colleagues, and the importance of planning. And you already mentioned about, should we downsize numbers? Should we close universities? Should we do this or should we do that? We might need to think a little bit outside the box and think about how to do that. And of course, we have diversion of opinions, we will always have, but it's important to take all the factors into account. If you like to know further about the education guidelines, and there's some useful documents with executive summaries that are easy to read. So after these documents were launched, we actually did, FIP made a commitment for education and a commitment for change. And this is part of the FIP Education Initiative mission, which is share the best practice and innovation, publish data, and that's our technical reports that we do each year that were mentioned already, and I'll mention them again. Centers of excellence, so the twinning between universities and sharing the best practices globally. Engage with leaders in academic sections, academic institutions, and we do have the president of the academic section here as well to speak to you today. So, and also we're launching a pharmacy workforce observatory, so that will be our big development for next year. So all the data that we've discovered, that we've analyzed so far will be available in a more interactive online database. Who likes Amy? You don't like Amy? You like Amy. Okay. Higher, wave them again, okay. So Amy has more votes than Penny, I see. Okay, that's good. So FIP started the education section, or the education part of their vision with this piece, which was the Vision 2020, and included the role of pharmacy and pharmaceutical science in education for the first time. In this year, beginning of this year, we have launched not only a strategic plan, but we have launched an action plan for the next 5 years to further develop the education within FIP. It is based in our needs-based educational model, which is it was mentioned before. So it is about the needs, the services, the competencies in education. But what we mean is it needs to be adapted to your country needs or to your area needs of practice. It allows flexibility and adaptability. So some of the FIP Ed tools, which is the Education Initiative tools and resources that we have online, and it's available for everyone. The Global Competency Framework is one of them, and you can download them in that link. The Quality Assurance Framework, and also our global reports. So in actual fact, this year we'll be launching at FIP. So Ian has actually shown the cover of our next technical report that's coming out in September, which is about continuing professional development and continuing education. So we have data and we have countries examples of how they do it in their country with that system. And we have the Global Quality Assurance version 2. So who likes the cover in green? I'm not counting. Okay. Who likes the orange cover? Yeah, I'm still winning. Doesn't matter. This is just a snapshot of the project that we're collaborating with the Royal Pharmaceutical Society about the global observatory that I mentioned. And the idea is to have that online database for our members to be able to see what type of data we have, to compare, to contrast with other countries, number of pharmacists, number of pharmacies per population as well. So some of the statistics and data and graphs that was shown in the morning, you will see them here translated into online platform. Another resource that it's free and you can download all of the articles in there, you just need to register, is our Pharmacy Education Journal. And it's, and it's available for everyone. We actually have a collaboration with IPSF about the essay competition. Who of you did enter the essay competition? Raise your hands. That many, wow. All right. So we did had an enormous number of essays submitted, and we have chosen a winner, and I think Fami will let you know some today or tomorrow or some along the days about who won the essay competition this year. And it's a collaboration we've been doing for 4 years now, or 3 years. 3 years, which one of the prizes is the winner gets the chance to get published and go through the peer review system of our journal, which is really good in terms of putting yourselves out there and having published your name for the first time. Who likes Bernadette? Okay. So between Amy and Bernadette, what would you say? Who likes Amy? Bernadette? Okay, Amy is clearly winning. Just to finish off a little of the presentation, because I'm trying to get us on time. The next FIP Congress will be in Thailand this year in September. It's a good thing, and it's a good thing for you to start thinking about that. Maybe not for this year, maybe for the next one, or even 2016. 2015 will be in Germany, 2016 will be in Argentina, which is a good place to go. Yeah, correct. That's what we were aiming for, which is a good place to go as well. But you will see lots of your friends there. And the beauty of IPSF and FIP is they actually combine together. It's an evolution in our associativism. So it's it's very rewarding to go back to FIP and see some of the familiar faces you will see next to each other at this Congress and in future Congresses. I know that for some of you this might be the first Congress ever, but some of the relationships that you've started here as friendships, you'll see that they will grow and they'll continue. So we do have a program focused on education, apart from all of the other sessions. So it's a heavy week programming, which is good also. Now I'm going to, how do you want to get involved with us? What would you like to do? And how can you contribute? So we do have students and we do have interns that were welcome at sometimes FIP headquarters. I did receive 2 students in Lisbon. They're here for the first time as well. And they did a 1-month type of student exchange program with me, which is something that we can always consider for some of you if you'd like to, even based from your countries. We do that. We do have the Student Learning Experience Questionnaire, which we are launching in force this year again. We have 7 different languages, so I would say that we've covered as many languages as we could for this year and for the past year to get as many responses as we possibly can. The essay competition I just mentioned. We also have a School of Pharmacy survey, which is still ongoing, and we're building a database, especially at one of our websites, which is the Academic Institution Membership. But how about a new project? What would you like to start? What would you like to see continuing? Some of what we mentioned today with Bill or with Luis, it started in 2002, with the 2001, with the Moving On 1 at that time. This is actually the Student Learning Experience Questionnaire. I think it's the continuation of the Moving On 3, so we just rebranded it. So this is one of the posters that FAMI and the executive did, and I think I like it in terms of a superhero. We've talked yesterday, who attended the workshop, we talked about a superhero approach or a dream team approach into collaboration of healthcare. So this was actually a very good chosen picture. Another idea that I can give you is we have all of these domains now currently at the development team. So we have 10 domains, and if you're interested in any of them, you can contact us and see what are you able to do. So for example, Brett and Stephanie, the students that were with me for a month, they focused on leadership and interprofessional education. So they did a literature review, and they also did some surveys and conducted some surveys and analyzed the surveys. And that for them was quite rewarding. So, and for us, it's very good to have that data feedback into our projects and into our technical reports. I'm nearly at the end, I promise you. Who likes Sheldon now? You don't like Sheldon? So I would say almost 80% of us like Sheldon. Maybe it's our scientific knowledge that would draw us to Sheldon. I don't know, but I think it's a good character for us to relate to. So some of the message that I want you to take home with today is be part of the change. Reply to students' questionnaire for starters, of course, because we want your views and your opinions. But also identify your needs and strive to be the best as you can possibly be. Education will always be part of our lives, regardless if it's focused in pharmacy or not, will always be part. So education is the core for everything. And we can't forget the patients. It's all about the patients. And we've spoken about this today often. I'm leaving you here also with some quotes from yesterday. We talked about what skills would we need to develop further. And we were talking about research methodology and social research. And is there anyone that attended the workshop yesterday here? Oh, fantastic. Great. So you probably see some of your words on the screen. I really like the first one, that it says, smile more. I think it's important. It's important to share your empathy with the patients and the dream team approach. Who knows the dream team of 1992 NBA? Yeah, that's why I changed to the Big Bang Theory. It didn't work yesterday at all. There was one person that knew about the dream team. But the dream team concept that I see is learning from your peers, but actually dovetailing with all of the other professional healthcares and ensuring the roles, so enhancing your capabilities among each other. So that's my concept of dream team we also need. And to finish up and to say that this is an honor for me to be here 10 years later addressing all of you in Porto. I'm Portuguese, as you probably know, so I would like to say thank you and also to remind you what we looked like a few years ago. So this is Cannes 2006, and this is 2 years after I met Professor Bates, but this was the year that I actually asked him if I could do an Erasmus in London, as well as Dr. Catherine Duggan, and they both said yes, and that led me to what I'm doing today and what I'm doing here. So in a sense, IPSF started all of this. And when we talk about roles of pharmacists, and when we talk about, oh, I'm going to community, I'm going to hospital, I thought I was going to be a community pharmacist. I'm a mixed pharmacist now, let's say it like that. I don't work in community, I don't work in a hospital, I don't work in industry, but I do work with associations. So there we go, there's lots of roles that we're still able to do. And there's always a pharmacist in everything, so think about that. To finish off, that's my email address if you'd like to contact us at FIP Education, and this is some of the links that you get, all of the resources and tools that we have. And that's it for me. Thank you. So since I'm the chair of this session, I would like to introduce you our next speaker, which is Dr. Catherine Duggan, and she's the Director of Professional Development and Support at the Royal Pharmaceutical Society, among other things. She was also my boss recently. She is my mentor. She is my role model. She's lots of things. So you would love her presentation. So please welcome Catherine Duggan.
Have you got me on yours? I'll have to swap.
Just bear with us for 1 second.
Seamless.
Spell us.
Great, thank you guys. Huge honour to be here. I promise that I will do my best to bring us back on time because I think I am the person standing between you and coffee, and you could storm me at any minute, I can feel it. It's lovely to be here, lovely to be with so many friends and colleagues, but also so many new faces. And I look forward to getting to know some of you over the coming hours and day. Okay, my presentation was entitled Continuous Professional Development and Advanced Practice. And I've really looked at what the other speakers were talking about and tried to make sure that what I'm doing is to reflect some of the things we've been doing in Great Britain, but to make it relevant to all of you. So for context, I thought it would be good to talk about the move that we've been seeing towards continuous professional development, and I use that phrase very carefully, to enable us to develop a flexible and capable workforce, much like other health professionals. I also wanted to talk you through the first steps that we've taken to developing a programme of support for all of us from day one of being a pharmacist all the way up to day 4,000, and to consider the place of assessment throughout this, and that then fed into my title. Oh, can I just ask in the room here, how many of you are in your studies at the university at the moment? Okay. How many of you are in your intern year? A few of you, yeah? Yeah, quite a few of you. And then how many of you have finished your practice and you're in your first couple of years of practice? Okay, lovely. And then how many of you have been qualified for so long you wouldn't want to admit? Yeah, okay, in. So I have different messages for each of you because I think this is really, really important for students who are in the system at the moment, all the way through to those of you who are 3 or 4 years qualified in practice. So we've been doing some work with pharmacists who are in their first days of practice. And what they've told us is that when I'm a student, I have my friends, I have my colleagues, I know what I have to do. I have to attend lectures, I have to learn the concepts of being a professional, but I know what it is I have to do to pass and to move on to the next year. This is in Great Britain, so the next thing is when I'm a pre-reg student, my main focus is my exam because then I can register and get a job. But I know what I need to do. I'm very clear about the things I need to be able to pass, the things I need to learn, the things I need to demonstrate. Oh, and I've got quite a good network of friends. So then day one happens. And our colleagues, and for any of us involved in education, this is really sobering. Our colleagues have described themselves as feeling abandoned, fearful, isolated, having lack of direction, feeling really pressurized in their first days as a practitioner in pharmacy, anxious, inexperienced, unsupported, and fearing the unknown. Now, colleagues, those of you who are newly qualified, can you relate to any of those feelings? Any of you? Or are they alien? Good, yeah, good to see only a few of you. What we want to do is we want to set up a program of support that moves those feelings into the green feelings. So from red to green, from negative to positive, to really capture some of the support that you guys show each other and make sure that when you are in those early days of practice, you can retain that and feel supported and know where to go. We've also been looking very much as a professional body at the hierarchy of professional support that we see pharmacists using. What we see in practice is if somebody is a bit insecure or a bit worried about not knowing everything, what we tend to do as pharmacists is go away on our own and look things up. I don't know whether this feels familiar. Go away and read a few things. And then when we feel a bit more confident, then we might actually go into a network and start talking about it. I think this also plays into the fact that we like to know everything as a profession. Then from the networks, we start to realize we're not on our own, that other people may not know everything either, and then we start to support each other. So we start to build these support groups. And then we can step into the role of mentoring, active support, active encouragement, feedback, assessment of colleagues, all the way up to leadership. So we're starting to describe this in Great Britain, and I wonder whether this is a model that we could start to think about globally. Alongside simple support and networks, we want to create a foundation program which lays out for you, on your first days of practice, the roadmap for your individual professional development. What do you need in your career, whether you're working in hospital, community? Hopefully these are applicable in academia and industry as well. But really they describe what you need to know, how you need to behave, perhaps some of the values and skills that we might gather along the way. And alongside that, over the next year, we want to launch support tools that help people develop themselves, perhaps assess themselves, perhaps be assessed by others, or perhaps even assess others themselves. Help us to identify not only what we're really good at, but what we might need to develop as well. And things that, although they're really important in our first 2 to 3 years of practice, can be used by any of us. I've been working in the professional body for 4.5 years now, so I haven't done some clinical pharmacy now for that length of time. If I wanted to go and see a patient and help them with their medicines, I'd quite like to have a tool or a framework that I could refer to. Remember what I showed you in the triangle? I wouldn't need to tell anybody, because I'm supposed to be a big grown-up, but I could go away and have a little look and see what it was that I should be doing, I should be able to do. Having that in your hands at any point in time is really important. And remember what Ian said earlier on about the numbers of people in our profession who return from career breaks like maternity leave. Wouldn't it be great to have some foundation tools that you can access at that point in your career? The other thing that we're building is networks. I've mentioned to you that pharmacists will tell us that they love networks. Indeed, look at you. There's a massive network here, but also what I see are clusters, groupings, like-minded individuals, people perhaps with a shared social agenda or a shared professional interest. And we saw that in the sessions before lunch, with many of you feeding back from different countries. I think those networks are invaluable. We want to create specific networks for the people who are in their first 1,000 days of practice, for people who are tutors, whether they are formal tutors, like tutors of pre-registration pharmacists, but also tutors of each other. That would be really revolutionary, I think. And then as you move on in your career, you're still tutoring and mentoring people who are coming up behind you. And some networks for those people who are returning back to practice after 1, 2, or however many children. So we've created a foundation framework. Much of this is built on existing frameworks and the evidence base that has shown that these things work, and a handbook. And the handbook really helps those who are returning to practice or changing sector. And they're also being used by employers. The foundation framework is made up of the 4 clusters that Andrea more or less spoke about earlier on, but really focuses on what you need to be able to do to serve patients, how you can build your own professional perspective from day 1 practice, how you can manage and organise yourself in practice, and then also how you can manage and organise yourself in practice. An example of this would be the patient and pharmaceutical care cluster. And you can see down the side are all the things that we believe you should be able to do, whether you do them all the time or some of the time. And you can use the grids for each of these competencies to check whether you're doing them a lot or a little. You can work with tutors and mentors to see what else you need to be able to know and do to move your practice up. Or you can self-assess and think, I need to focus on this area a bit more. And for someone like myself, if I was returning to practice, I could use this to see, I must remember these are the things I used to do without thinking. We've also got a range of assessments that really, I think, help to support not only the individual understanding where they can improve or develop further, but also tutors and a culture in the profession that we all need to be able to develop further if we're going to strive for excellence. One of the big things in this area is peer assessment. It's something that our medical colleagues do very routinely. It's part and parcel of their job. And I don't mean peer assessment or managerial assessment. I'm talking about how it feels to work with somebody professionally. That's something quite revolutionary for us as a profession. We're very used to being fed back to from a manager rather than from a peer. We've got other tools where we can self-assess, like our pharmaceutical care assessment tool. How am I interacting with a patient? How am I benefiting this patient in practice? How can I gather that together so I can present a compelling case that I've made a difference in? And remember what we were talking about before lunch, where we need to be able to make that difference and talk about it if we are to be part of the patient's solution. Some direct observation of practice, which is really good in clinical or manufacturing situations, for example. And many reflective tools as well. I've got one I wanted to show you. I can't get into it today, but this is one that we've just launched recently, which is really exciting. For somebody who's just starting out in their practice, you're able to annotate and label about 200 medicines, using this in this type of patient. Beware of X and Y and Z. So it's a little bit like your own compilation, your own log of learning around medicines. Indeed, we've called it your tool to gather the in-depth knowledge required to be a medicines expert. Understanding that when you start out at day one, you have all the knowledge you need and all the theory you need, and then you can feel very insecure because you aren't totally experienced in practice. Foundation framework can be used firstly to ensure all of us are able to demonstrate where we are with essential skills. Before moving on, if you think about our journey here now, and I'll talk you through the place of assessment with this, we have our MPharm, which many of you are involved in, an equivalent, that's your degree at university, then your pre-registration year, then this foundation practice time, and then you can move on into what we called our faculty membership. So what exactly is the RPS faculty and where's the place of assessment in that? In 2012, we undertook quite a lot of research because many of our clinical colleagues had said what we need is a way in which we can demonstrate that we are at the same level of specialism or generalism as our medical colleagues. We need that. So we knew that clinical colleagues wanted it, but was it desired by industry or academia or community? And in hospital, there are managers of production units. Did they want it as well? Actually, we found that everybody wanted it. What they really wanted, and I think what now we have in place for colleagues like you to just come through, is a flexible and consistent method of recognising what you do in practice wherever you work. Note my word, consistent here. It's a consistent way to provide evidence of capability as well as effectiveness to patients and the public, to people who pay for the health services we deliver, and your bosses. This kind of thing is exactly what colleagues were calling for earlier on before lunch. And it's a consistent way for your experience and practice to be recognised across a more mobile workforce. So this would mean that you're able to move from sector to sector with your portfolio ready to take on new roles because your experiences, your knowledge and your skills are transferable. So, 4th of June 2013, we launched the Pharmaceutical Society faculty. Eligible members have access to a portfolio online, a framework which underpins it. We have guidance about how you can use that framework. We have different handbooks for different sectors. We've just launched a specific one for community pharmacy. We have professional curricula, which can act as support tools. The kinds of things that you need to be able to know and do at this stage of your practice include led by the peers and experts in the profession. We have, with the starting up of a complete library of what you can go and learn from to help you with your portfolio. So a bit like a library of quality assured education and training provision. We have the starters of a mentoring scheme. And I'll talk you through that because much of what we're talking about for our foundation pharmacists at the start of their careers is absolutely crucially dependent on mentorship all the way up to the top. Remember what Ian said about the top of the profession being the anchor point. If that isn't high enough, then our anchor isn't strong enough. Opportunities for networking, exactly the same as our foundation colleagues. And then some support resources, how-to guides, quick reference guides, handy tips. What is it we need to be able to know and do? Well, we have 4 clusters in the foundation framework, but actually, if you think about it, they map absolutely onto the competencies that you need when you advance. So there's lots of bits of education, research, management, expert practice in the foundation framework. It's just organised in a slightly easier way for our junior colleagues. On the right there, you see all of the competencies that we need you to be able to demonstrate as you advance. And these clusters are simply ways in which we've bundled them together. But you may have led on a big change in service. You may have led on a new educational programme. You may have had to put in place a new service redesign in your practice. And you could use that evidence across many of these competencies. It's the impact on the patients and the profession that counts. And here are our frameworks and support tools that fit. All RPS members who are more than 2 years registered, i.e. beyond foundation practice, have access to all of the faculty tools, the frameworks and support. And we know that many people are frightened of getting started, so we have a whole series of support and webinars and networks to help them with that. And then when they're building their portfolios, they're fine, but then they get a bit frightened when they're ready to submit. So we have networks, support, webinars, lots of peers now, lots of champions, faculty champions, who are helping each other build and support them right to the point where they submit. Now, wanted to focus just a bit on the assessment. What we've done is, for those people who are more than 10 years qualified, we've put in place a scheme called Recognition of Prior Experience. The literature is well known around this, that after 1,000 days of practice, you have created about 10 years of practice, 10,000 days of practice, I should say, 10 years of practice where you are regarded as an expert. And we want people to demonstrate breadth of experience in practice through a portfolio across all of the clusters I mentioned before. That's good. That kind of says, if it was me, how Catherine says she's brilliant. So then you have to submit your CV, which is an objective way in which all of the roles you've held throughout your career show you're brilliant. And then we need some peer assessments as well, so that others can say you're brilliant. So it's not just one perspective the whole way through. As we move to the assessment of those who are between 2 and 10 years in practice, we will also be adding in an expert practice assessment. This will be based on the area of practice you're in, and it will help to augment your CV at that time. So if, for example, you're in a clinical area, then the clinicians from that area would be assessing you in practice through a case-based discussion as a minimum. So as you come through your foundation program, you're very used to these tools and these methods of assessment, and it becomes natural practice for you. So the 4 stages to professional development that we have include our foundation stage, the foundations of your practice. As I mentioned before, these are for those who are newly qualified, returning to practice after a career break, after a sector change. And then we have our 3 stages of faculty. Advanced stage 1, experienced established practitioners, possibly the majority of the profession longer term. Advanced stage 2, those who consistently demonstrate excellence in practice, not far off the majority as well. And then we have our mastery stage, or those who are fellows of the faculty, and they really are exceptional practitioners. And we have a big myth in Great Britain, which is, oh, you know, if I don't get mastery, then I'm not very good. Actually, this is all about advancement. And if we are thinking that fellowship is exceptional, not everybody can be exceptional. We have to think about how the curve looks. Speaking of the curve, what this is really about is the fact that we have a distribution of ability and capability in our profession. And very often, when you have leaders in the profession, or you have experts, or you have clinicians, the tail on the right-hand side of the curve can stretch and stretch and stretch. And those who may not be performing very well can end up isolated and on their own. What we need to be able to do in pharmacy, and if you think about our discussion about student numbers earlier on, is to provide the opportunities for everybody to advance, for everybody to excel, and for everybody to have an equal opportunity to do so. So that what we do collectively is we move the workforce capability always forward. That's the role of a professional body. That's what professional regulators want. They don't want to see us providing only support to the excellent, only support to the specialists. They want us to be providing an equitable programme for everybody to access. That's a real challenge, but it's also such an opportunity. Everybody has an equal opportunity to excel, to be the best they can be. And in Great Britain, at the moment, we're having a big review of continuing professional development, the requirement to keep you on the register as a professional pharmacist. At the moment, you are assessed every 5 years for the numbers of records you've put on the register, which have shown that you've continually professionally developed yourself. We understand that that's fine in one way, but that actually I'm very different in my practice to when I was newly qualified, and it's very difficult for everybody to be able to be assessed at day one practice. What we really need to do is to have a way in which I can demonstrate that I can continue to be fit to practice to my regulator. What the regulator's interested in with this is peer review, some CPD review through a portfolio, for example, and perhaps even some measure of performance. So we want them to regard the faculty model and the foundation model longer term as more than the gold standard for this. So if somebody has their Royal Pharmaceutical Society credentials, that's an absolute guarantee to our regulator that they are fit to practice. This is all very early days, but it's very exciting. And this is the quote from the regulator saying they want to work in partnership with us on this. So as a practitioner, if you have your portfolio, you have your CV, you have your practice assessment to go alongside that, and you have your peer assessment and testimonials, you should be assured that that will more than suffice for continuing fitness to practice. Lots of work to do on that, but that's what we want. What we also want is to provide an environment whereby leadership is around everything we do. Everyone can have access to mentors. What we're finding is it's often very tricky for the most senior people in the profession to understand their need to be a mentor and to be mentored. Many of those elder statespeople in our profession did it on their own, and they never needed any support. Actually, we need them to support others. And then those can support others, and then those can support others. And it all comes back to you guys supporting the ones just below you in the professional hierarchy, and we have a self-fulfilling cycle of mentorship. We want this to surround everything we do for the foundations of our practice and to support those who want to enter the faculty to do so. In this way, our vision of MPharm to faculty provides us with a continuous professional development and advanced practice programme underpinned by continuous supportive assessment. And the big word there is support. We're bang on time, team. Thank you very much for your attention. Don't let me go down the stairs.
No. So I think we're We're going to have a break, or we can have questions first. Let me know what you think. We can go for coffee, and then we hear our last speaker and have questions. Coffee, is that what you mean, coffee break? Oh, you have a question, right. Good.
Cuckoo. Thank you for your presentation. I was just wondering, you were talking about improving the competence of all the pharmacists at the same time, instead of improving just a few. Is it possible?
If we start from the point that everybody leaves university and their pre-reg the same, and we offer everybody the same opportunities to develop, then yes, we can deliver that. Whether the curve stays exactly the same or broadens out may change over time, but we need to measure that, and no one's done that before. I think the thing that we need to hold on to is that you all start your degrees as very smart students leaving school. And then, where does that go after 30, 40 years of practice? For some people, they become smarter and smarter and smarter. And for others, they lose confidence because their role can be repetitive or unstimulating, or they focus on what they do rather than what they need to develop. So I'm really interested in the people above the line, brilliant. But they always will be brilliant. It's the people below the line, we need to think about how can we support them better. The reason I think I can be confident saying we can support the workforce to be better, not we will improve the workforce, we won't do this to the workforce, is that research in 2012, where every single person we went to see said, I just want to be the best I can be. So I think we can start with that hypothesis at least.
But do you think everyone leaves school at the same level?
No, and the curve doesn't mean we're at the same level. What the curve is showing is that the whole workforce needs to have the opportunity to move up. We cannot have a pharmacy workforce that is so flat that the people at the top bear no resemblance to the people at the bottom.
Yeah, I agree. Okay, thank you.
Does that make sense?
Another question over here?
Thank you for your speech, Dr. Duggan. And while hearing your speech, I thought like we are all university students mostly, and I couldn't really understand specifically about the assessment because I've never been into practice. I've never experienced anything, and just hearing about assessments, I couldn't really understand it fully. So could you explain specifically or give an example of how assessment helped someone, or how someone could be improved by the assessment? Thank you.
A lot of the way in which we're building the assessment portfolio, we've learned from medics, but we've adapted it for our profession. So what they do really well is they have small assessments, self-assessments of what you're doing in clinical practice. So you can constantly assess yourself against what you know you should be doing and look to improve. And then every now and then you can take a load of those and discuss them with a tutor or a mentor in practice. That's a brilliant way to just see what it is you're doing well, but also see where you could improve. So that's the clinical experience. Then we have some ways in which you can log what you're doing, so you can record them. As a profession, we're really bad at recording what we do in practice. We know this across all countries. We have intervention weeks in the UK. We have similar models across the rest of the world. We should just be doing it routinely. So these little tools will help us write down what we're doing, and not just write it down, but think about what the impact on the patient is, or the impact on the drug budget is, or the impact on that patient's quality of life, for example. The peer assessment tools, as I say, are really learned from other professions as well. So these are ways in which people can write lovely things about you, of course. She's great to work with. so diligent and motivated and confident. That's what everybody should be writing. But additionally, some really objective things as well. So some evidence. And the really good thing is that this isn't just from your seniors, who you might be impressing. These are from your peers, so people at the side of you in practice, and often from others who may be more junior than you. So you get this full, what the literature would call 360 perspective of what you're really good at and what you might not be good at. And this is very good for learning to be your own independent professional, because we have to kind of put a persona on to go to work. You need to be a little bit natural, a little bit like yourself, but you need to also be very held together in a good way as well. So that helps with that. And the other thing, just to let you know, we had some community pharmacists going through the faculty, and they asked patients for some assessments. Very objective, no, very subjective, very, qualitative. But I thought that was amazing. That was really brave. Really good. Does that help? So, there's loads of literature on assessments. This is supposed to be a very brief taster, but it looks like you're interested.
A couple of more questions, but then we have to break for a coffee break. So we'll take the 2 questions on a row, if that's okay.
Okay. Hi, Catherine. There is a clear division between hospital pharmacists. Can you hear me now?
We can't hear you, sorry.
Okay, so there is a clear division in hospital pharmacists and community pharmacists in England. And I've heard from hospital employers that they said they wouldn't employ pharmacists from a community background just because they perhaps not have the training or the experience. Do you think that there is a competency network that can kind of make pharmacists more transferable, not just in the hospital section, community, as well as in industry and academia?
I absolutely agree. I think these divisions are fake, and I don't know the evidence for them. I think we need to have the evidence for completely the opposite. So this will offer it for you. If you're a hospital pharmacist, if you finish your foundation program and you have an RPS badge that shows you are exactly the same as a community pharmacist, industrial pharmacist, academic pharmacist. Our ambition is to give you the portfolio you can carry wherever you go. Even if you have a little bit of a gap to build when you move into a new job, that's fine. That's our ambition. Not a model for community and a model for hospital and a model for industry. This is an umbrella model. And I think a lot of colleagues who say we can't employ a community pharmacist to work in hospital, I think it's come from a non-evidence base. So I'd be really interested to see why they think they can make that statement.
I think it's mostly because in hospital they're provided to do a general diploma when they're employed, but I don't think there is such things in community and they're not funded to do a standardized diploma afterwards, and hence that's where they differ.
Absolutely. So what this will do is it will provide everyone in your first 2 to 3 years with the same program, and we're working with the diploma colleagues to make sure it maps onto it. But if you didn't have a diploma, we would support you to be exactly the same stage.
So this is targeted to those who's not working in a hospital, who already have the opportunity to do it.
This foundation program is your foundation program, whether or not you have a diploma. You can get to the same endpoint through this program.
Okay, thank you.
Thank you. Just a final question before we break for coffee. Thank you.
Hi, I'm Keisha from BPSA UK. Right, just a quick one. It is nice that the foundation program is to help with pre-regs and then the faculty for people in their practicing years. At the moment, most of us here, I would think of still students. So how would we, as students right now, start to prepare ourselves to have the right mindset in continuing our professional and learning development? Thank you.
Well, we're going to do a big launch of this in a few weeks' time, And what we want is to create networks. For the foundation programme, you've seen the 4 networks, but we want to also encourage students and pre-regs to get involved, to start becoming familiar with the foundation frameworks, and to start seeing how they could even use them even before they start practice, and feed back to us. What we'd really love is to get some people in their first year or 2 in practice to mentor some students as well. So all of the ideas that you have for how you want to get involved, let us know. But we will be launching a big programme of getting involved, including stories from those in their early years, and then how they might have found the support has helped them. And they let us know which support they need. So this is absolutely rich for you to get involved in. We really want to be providing a similar type of approach all the way through from day 1 in student life. It's taking us perhaps a year or 2 to get it all joined up, but definitely be part of it, definitely. Look forward to seeing you.
Thank you. Thank you, everyone, for your questions. We'll break for coffee now, and we will turn maybe 10, 15 minutes, if that's okay. Yeah?
Hello?
Hello, everyone. Can we invite everyone to please sit back in back in their seat so we can start the next session soon. Thank you very much.
Do you want the note or okay? Do you
think
want it
I
now or later?
Later is probably better.
Okay. If you want, I write your note, and then you just have to read it.
Okay. Good. Thank you.
Hello, everyone. Can we start sitting, perhaps, for our last speaker of today? Yeah. Can we start, please? Can you sit down? Thank you. Right, the slower you sit down, the slower we'll start the presentation, and therefore prolonging hours here. Okay, I'll start. Let me introduce you to our final speaker of today, Professor Stephen Eckel. He's a clinical associate professor at UCN School of Pharmacy. He'll tell you a little bit more about himself and what he does, and talking about professional development to professional progress. Welcome him.
Thank you. It's a privilege to be here and meet so many of you. At the break, I just happened to pick up this Congress diary, which I found one of the most interesting things I've ever seen in a sort of dialogue about a meeting. But more interesting was how it referred to the panel of speakers today, was people with lots of great personalities. And so I've never been introduced that way. I hope after talking to you for quite a while, you might think I still have a great personality, but it's been our pleasure, I know all of us, to come and chat with you and talk about areas that we have passion about. And this is definitely something that I have a lot of passion on, and it's really around the concept of career development. For the past 15 years, I've been involved in pharmacy residency training at our organization. And we have over 30 pharmacy residents that train at our hospital. And so throughout the last 15 years, I've really been able to invest myself in lots of dynamic individuals that have not only come to our organization to learn about how to practice pharmacy, but then also to go to places all around the world to pass that passion on to people. And then really over the last 5 to 6 years, I've gotten involved in pharmacy administration training individuals to be leaders of hospital pharmacy departments, making sure that they're really good stewards of the assets that they have, whether that's drugs, whether that's people, whether that's money, and then also creating and planning a vision for the future where you learn to lead groups of individuals from point A to point B. A few years ago, I started transitioning over to the academic side, and so have been involved in teaching and training individuals on topics within pharmacy administration, while at the same time still working with individuals in the hospital side. And so I really like the opportunity of balancing the two environments, both academia as well as practice. What we're going to be talking about today is a concept that I think everybody should think a lot about. And it really, from my perspective, pulls together all the different concepts that we've been talking about over the last 4 to 6 hours. And if those of you who were here during the break time, when the question was asked, what do you think about capping of pharmacy schools? And I quickly, for myself, said I firmly believe in the free market. But secondly, when we talked about what should you do, my response was, I think you need to focus on yourself. And you're the only one you can control. And with that, and sort of through that, then we're going to be talking about in this presentation how you can go and worry about yourself and be prepared for the future of healthcare delivery in any context, whether community or hospital, and in any country, whether a low-resource country or a high-resource country. I will also be doing 4 sessions over the next couple of days, and those are titled Innovation and Entrepreneurship. And that's really at the business level. How do you start new businesses? How do you create business plans? How do you launch new services? And so this one is not going to be, we'll talk about some of the same things, but this one is really going to be talking about inside yourself as opposed to the external environment. So if we could bring our slides up, that would be helpful. They were there a second ago. There we go. Thank you. So today I want to talk a little bit about career planning and how do we begin thinking about it, and then really talk about this idea of aspirations, assets, and market realities, which is probably something you've not thought a whole lot about, and then really talk about, now that you understand it, how do we sort of advance ourselves into the future. And I'm drawing some from this book called The Startup of You. And I think it's a really interesting book, and it's written by a guy named Reid Hoffman, who was the co-founder of LinkedIn. And if any of you have a profile out on LinkedIn, you sort of recognize sort of the connections that it allows you to do and get to learn about people. But I found it to be a really interesting book, and we'll talk some about the parallels into it, as well as maybe sort of differ for some of it and bring some other things in there. So I'm guessing all of you have heard this being said at one point in time. The best way to prepare and plan for your career is to determine where you want to be in 10 years. And once you sort of figure out where you want to be, now come up with a roadmap to get you there. I know that's exactly what was told to me, and I'm sure I've expressed it to other people as well as you've probably heard it yourself. Unfortunately, the reality for today is the world is changing faster than it's ever changed before. And if you've heard something called Moore's Law, this idea that we're just exponentially getting faster and faster at the way we do things, and so this idea of planning for 10 years out, we don't have that opportunity anymore. And there's many reasons for that, one of which is that the complexity of healthcare today is so much different than it was a few years ago. And the technology that's coming out, the new drugs that are being developed, the way we communicate with each other is so different that it's hard to plan for the future. The other interesting perspective is our future doesn't even exist yet, potentially. So when that question was being asked about should we cap the number of people becoming pharmacists, we're not exactly sure what that future will be. And so those jobs that require skills of people that are pharmacists might only be coming out in a few years, and so we've got to sort of be ready for that. And this idea now of change now or become irrelevant, or the quote that Ralph used, I think was attributed to Dennis Helling, was if you don't like change, then you'll enjoy irrelevance less, is this idea that things are moving all around us, and so we either need to be moving or we're going to be standing still. So I want to introduce this term of entrepreneurship. We need to rediscover our entrepreneurial instincts and forge new roles. And you must identify areas of incomplete knowledge in yourself and your profession and then fill those gaps. So I'm hoping everybody has heard this idea and context of entrepreneurship. And I wonder, do you think that you're an entrepreneur or not? And this book starts out with an interesting quote that's attributed to Muhammad Yunus, who was a Nobel Peace Prize winner for this idea of microfinance and lending a little bit of money to people and really allowing them to jumpstart sort of individual jobs. And he says, all human beings are entrepreneurs. When we were in the caves, we were all self-employed, finding our food, feeding ourselves. That's where human history began. As civilization came, we suppressed it. We became labor because they stamped us, you are labor. We forgot that we are entrepreneurs. So maybe at the beginning of time, because we had to find our own food, we had to protect ourselves, there's this idea of entrepreneurship that sort of came out. Then he later states this really interesting quote, and he says, in this book says, if you want to seize the new opportunities and meet the challenges of today's fractured career landscape, you need to think and act like you're running a startup. So what do we think of entrepreneurs? We think that they're out there leading and starting new companies or new opportunities out there. And there's a lot of risk, there's a lot of things that they have to do to be successful, and there's a lot of fear associated with it. And so you're always working and you're always developing your company, your product, your idea. Well, he goes to state that you're running your own startup, and that startup is your own career. So you need to think like an entrepreneur within yourself as much as a new entrepreneur that's a CEO of company is thinking about themselves out there. The conditions in which entrepreneurs start and grow companies are the conditions we all now live in when fashioning a career. So I want to start out by suggesting you need to think of yourself as an entrepreneur. And now what we're going to do based upon that idea is just what an entrepreneur does when they have a startup of a new company. You need to think about that in your own career development. And the way you approach yourself, the way you approach your future is exactly just like a CEO starts a new company. So let me ask you a question to think about. Do you believe people have intelligence and or talent that are fixed at birth, or does it change over time? Do you think somebody's talents and knowledge or intelligence are fixed at birth? Well, if you said talents and intelligence can be developed, you're sort of identified of what they call the growth mindset. If you answered the question that it's static, you're in this concept called fixed mindset. And if you begin to start reading educational literature, they bring out this idea of growth versus fixed mindset. And so people that are in the growth mindset really have a desire to learn. They embrace challenges, they persist through obstacles, and they learn from criticism. And I contrast that with this other idea, which is the fixed mindset. As opposed to having a desire to learn, they have a desire to look smart. And because of that, they avoid challenges, they give up easily through obstacles, and they ignore useful feedback. It doesn't really matter how you answered that question because anyone can change. And my hope is that everybody moves from a fixed mindset to this idea of growth mindset, because that's really where we need to focus and be preparing ourselves for the future. And this concept that Lisa mentioned in the book is this: you need to be in a statement of permanent beta, or in essence, you need to always be growing. Anytime a company says, I've learned everything, I've arrived, I've done something, they're quickly going to become irrelevant because they always need to be optimizing, either finding a way to do something cheaper or finding a way to do something in addition to what they're currently doing. And that's the same for you as future pharmacists and professionals. You always have to be advancing, growing every day, because somebody out there is going to be doing it if it's not you. And so this idea of entrepreneurship and adaptive skill has to grow. So one of the questions you should ask yourself is, what is my competitive advantage? If I look at pharmacists within my country, if I look at other healthcare professionals within my country, or other individuals in which my sectors are, what do I add that others do not have? Or what can I be that others cannot become? And that's really, I think, a critical question you need to answer for yourself. And I'm actually going to give you a few tips on how to begin thinking through that for your own self. And part of that is you need to invest in yourself, and some of that could be meaning changing your environment. So there's this idea of what they call ABZ planning. So each of you should come up with your sort of plan A. What is that moonshot? What is that long-term goal that I really want that's out there? Where do I see myself differentiating, and how do I sort of get myself into that competitive advantage? And then secondly is, what's my plan B? Well, what can I iterate to? Plan B is just a little bit different from plan A. And what can I iterate to that if for some reason plan A doesn't happen, I might transition a little bit to plan B? And then you need to think about, what's your plan Z? Meaning, if everything fails, what can I fall back on? Well, one of the beautiful things about all of us is we can always fall back on pharmacy. We can always be a pharmacist. So even if I'm pushing for something way out here, I always have something I fall back on. And so those are things that you need to think through about, what is my A, B, and Z. But let me talk about a little bit about how do you come up with your plan A. And there's three concepts I want to bring out here: aspirations, assets, and market realities. You need to think through what are your aspirations, what are your assets, and then what are the market realities in which you work. So your aspirations, what would you like to do in the future? What are you passionate about? And we'll talk a little bit about that in a second. What are the things that you really find enjoyment in? And where do you want to sort of develop yourself? I started out this talk giving you a little bit about what I'm currently doing today. 15 years ago, when I started in practice, I would have never have put down on the paper what I'm actually doing now is what I did then. I guarantee you, each of the speakers that came up here probably would say the same thing. So you might have aspirations, but you need to sort of understand them. Secondly, what are the assets you have? Just like a company has assets, whether it's resources, whether it's location, whether it's property, you have assets. And there's two types of assets. There's soft assets and there's hard assets. Soft assets are, what are my knowledge, skills, abilities? What are my connections? Who do I know? Who am I related to? And then there's hard assets. Some of that could be, how much money do I have in the bank? Or how much debt do I have? And based upon the way you answer those hard asset questions, really changes your risk profile of what you want to do. But you need to think through, what are my soft aspects? Am I a very good public speaker? Do I enjoy marketing? Do I enjoy selling things? Or do I really like process? Do I really like policies? And then the reality of it is what will the people actually pay you to do? So it's one thing to come up with your goal, but then you need to ground it in reality. Unfortunately, I find more people, though, view reality with too much pessimism. What I mean for that is, I think there's a lot of ways to do things that we don't think about. So, for example, one of the issues we have in the U.S. right now is payment for services. Can we get paid for doing things in the clinic setting beyond drug dispensing? And most people say, well, we can't advance ourselves until we've figured out this conundrum. On the reverse side, at the hospital I work with, I've got 25 pharmacists that are currently working in the clinic settings, and they're working and getting paid for their services. Well, how are we able to do that? Well, we kept thinking through, what can we do, what can we do, what can we do? So don't just limit yourself to the market realities, really think big in relationship to that. So let's break these down a little bit further. Aspirations. You've probably heard everybody say you should find your passion and then pursue it. Well, let me let you think something different about that statement. The problem is passion can sometimes be flighty. I want to introduce an idea to you about creating a loyalty. You need to create a loyalty, and what I think the difference between loyalty and passion is something that it just sort of comes and goes. Well, I like to do this today, but I might not like to do that tomorrow. Versus I think when you have a loyalty, you have the ability to stay with it, even though it might not be giving you everything you want. It might not be as enjoyable as you want it to be, but that loyalty allows you to continue to advance yourself, to continue to go forward. And so with that, I want you to sort of think for a second, do you have a loyalty? Is there something that's a little bit beyond passion that you have that you're willing to contribute to give to continue moving forward? For me, I have a lot of loyalty to UNC where I work, and I have a lot of loyalty to hospital pharmacy. So I've got career aspirations and passions that I'm after, but for me, in some senses, because of, I feel like things I've enjoyed in hospital pharmacy, the things that I've enjoyed working at UNC, I would like to continue to do that under the brand of that loyalty as opposed to not doing that. So each of you might have some different loyalties, but I want you to think about this idea of loyalty. And this is something Atul Gawande, who you might be familiar with, he's a surgeon in the United States, and he's written a book called The Checklist Manifesto, really begins talking about this idea of loyalty. And I think that it's important to think about it from the different perspective of just passion. The next thing any new CEO does in their new company is they write their mission and vision statement. And I think each individual should write their own personal mission and vision statement. The mission is really what you daily work toward to achieve your purpose, whereas your vision is really what you want to be in the long term. And then based upon that, you also write things like your value statements and your priority statements. Again, you go to any company's website, you'll see their mission and vision statement. And the same is true, it allows you as an individual to sort of give you a North Star, to let you go back and look and see how am I doing through that. So I want to encourage you to do that. The other thing you need to sort of think about in crafting that mission and vision statement is you need to talk to others. A lot of times in professional circles, you'll hear this idea of mentorship. Who are your mentors? Who's helping to grow and develop you? And those people can have a tremendous insight into who you are. Not only can they tell you some things about your own strengths and weaknesses that you don't see, but they can also provide you with opportunities that you're not aware of. And I highly encourage people to have sort of networks or colleagues that are not only professionally based, but individuals that are personally based also. And then as you sort of come up with these aspirations through talking with other people and sort of bouncing them off, your personal aspirations and your professional aspirations should be in alignment with each other. They should not ever be in conflict. So one of the things I would encourage you to do, and we're not going to take the time right now to do that, is begin writing your own personal mission and vision statement. Begin getting on paper some of the things that you want to sort of have come true in your career. Some ways people, Stephen Covey is an author I highly respect, and one of the ways he says for you to write your mission and vision statement is think about your own funeral. What would you like being said about you at your own funeral? What would you like people to describe your life as? And when you start hearing that or thinking through that, you start seeing some themes of how you want to be known, things that maybe you want to have been done, and then that allows you to begin sort of building your mission and vision statement. And it allows you to sort of see some things about yourself that might be important. So that might be a good way for you to start. The other thing is go out on the internet, and there's lots of examples of not only companies' vision and mission statements, but personal ones. And you can utilize them to sort of help harmonize and understand what you want out there. So the reasons why I think it's important for you to have your own is that it really begins answering what is your sort of career goals? Where do you want to go? What do you want to do? What kind of person do you want to be? What do you want to experience in your life? And what are some things that you want to contribute? And it allows you then to be something that you review back to at different points of time. Here's a colleagues of my sort of personal vision and mission statement, and this one, to me, is a little bit longer than maybe what you see, but you see some of these bolded words, like they have power to be vulnerable in sharing life and authentic communication, suck the marrow of life, seek interdependent relationships, spread compassion contagiously. So when you start putting this stuff down, then it allows you to sort of guide you what you want to do and what experiences you want to take. So that's the first sort of leg of the triangle in relationship to developing your career. The second one I want to talk about is sort of your assets. And again, I mentioned those as both your soft assets as well as your hard assets. And so some of the soft assets might be is your connections. One individual up here earlier talked about their grandfather was a pharmacist. Well, you might have other family members that are pharmacists. And having that understanding opens up connections where others of you do not have that. Maybe some of you have a next-door neighbor that is a CEO of a pharmaceutical company. Well, those are connections that you need to understand and come to appreciate. Then secondly, all of you have some different degrees of knowledge. The question was asked in the last section, do you think everybody graduates schools of pharmacy equally? And the answer to that was no. And so you might be on the front end of the curve or you might be on the back end of the curve, but again, each of you have different knowledge, skills, and abilities that are important to take into appreciation. Some of you are better communicators, others of you are not. Some of you like to speak, some of you like to write. And then some of you have optimistic outlooks, some of you have pessimistic outlooks. Some of you drove to the growth mindset side, some of you identified with fixed mindset. Again, working through who you are and understanding that allows you to have a better understanding of what are your soft assets. So I encourage you to spend some time, maybe it's on your plane ride home, maybe it's a day of your holiday, to sit down and begin writing out what you see as your assets are. And then I encourage you, give them to a friend, give them to a family member, give them to a peer, and say, this is what I see about myself. Do you concur? Do you agree? Or do you see other things in me that maybe I wasn't even aware of? And all those things really help you come up with a future. Now, the thing I want to bring out to you is the knowledge you need in practice is always changing. I think I said that earlier, is that the career you might be in might be something that's not created now, or for sure something that you have never thought about. Secondly, you'll never know everything. It's impossible. Actually, I tell my residents, you will know the most about pharmacy when you graduate the residency program. And then after that, you specialize. You lose a lot of that information, and so it's just the fact of life. If you ask a CEO, every day brings a new challenge that I have to think about, I have to be prepared for, I have to be ready to handle. And that's the same in your career. Something's going to happen tomorrow that you hadn't predicted, you hadn't planned for. Are you ready? Are you ready to handle that? Those are all things that you need to sort of think through and get ready for. And this idea of continuing professional development, which we just talked about, is an idea that I think everybody can do not only for their own knowledge and skills for pharmacy, but in some ways for their own career development. You develop a plan, you act on that plan, you go back and evaluate that plan and reflect, and then you continue to iterate that plan. Again, all these ideas that we've been talking about throughout the course of the day really comes together nicely, not only for your professional career, but also for your personal career and where you want to go as a professional. So again, I encourage you to develop a plan for your soft assets. Now you might say, networking. I find networking to be very stale. I think it's fixed and contrived. I don't enjoy doing that. Well, let me sort of not think about that term networking and sort of remove yourself from that networking, and we'll talk about sort of relationship building. I think relationship building is probably a more appropriate term than networking, and I'll explain to that in a second. But in your sort of professional network or your mentors, I think there's sort of two concepts of people that you want to have, one of which is allies, and then further on, sort of your weaker ties. What are your allies? Well, I believe your allies can be 10 to 12 people that are the closest to you. And those are the people that you always go to. Now, one of the things that's important to recognize is that 10 or 12 people can change over time. So right now you're in pharmacy school and you probably have very close pharmacy friends, and you would populate that 10 or 12 probably with some pharmacy students. Well, 5 to 10 years you might not have seen them again, and they will be sort of changed out with other people that are meeting a specific need at that point in time. And with that, you sort of share with each other. And then I would always also encourage you to come up with what I would call weaker ties. People that aren't like you, they bring a little bit of diversity, they're outside your circle or your profession, and they provide great information. I believe many people sitting around you today could be your weaker ties. Just by practicing in a different healthcare setting, a different healthcare system, going through a different educational model can really sort of provide you with things that you might not have thought about before, and that can be very helpful for your own personal growth and development. And the one thing I want to bring out, just like you have to water flowers to have them grow, you need to water your relationships. You need to give to them and continue to grow them by getting stronger. You can do that through sending them articles, helping them be successful in their career aspirations, collaborating with each other, or staying in touch. And this is this idea of relationship building versus networking. I think networking has a negative connotation, and by that I mean they just want people to help them. So they reach out if they need something. They think about how important those people are to them, and they try to have as many of them as they can. On the reverse side, this concept of relationship building is, how can I help other people? So how can I help them be successful in what they want to do? How can I help them achieve their own career aspirations? And many times, what you get out of that is reciprocation. Somebody invested in your own career growth. They help introduce you to other people that might be helpful to you. But it all starts by you giving to them first, and then they give back to you. So I encourage you to think about, in your allies, how can you be a relationship builder to them, not how can you network to them for your own success. And then third, after you've done your aspirations, after you've done your assets, let's think about the market realities. All of us are in a healthcare system that's changing. All of our systems have greater needs than they have resources. All of them, as sort of the Ian Bates shared on the first talk, some don't even have enough resources based on healthcare workers. Some maybe have too many, but I guarantee if you go to all those that said they have too many, they still would say they don't have enough. So how do you work in that market reality? What are some of the risks out there? So patients have to get their medications. Patients have to get educated about their medications. So what are the risks if there's not enough pharmacists? Or on the reverse side, what's the risks if there's too many pharmacists? What if we have more and more graduating from schools of pharmacy? What are the risks out there for me as a professional? Who are my customers and what's the reality in which they live? So we have to ground ourselves in that, even though we don't want to be too pessimistic about that. So I encourage you, think through what are your current market realities? What are those things that I live in day by day that challenges me and maybe limits me from reaching my aspirations? And that at least allows you to sort of think through that. So what would a CEO of a new company think about if they were coming out with a new laundry detergent? Well, they would think, well, what are the current laundry detergents out there and how expensive are they? Can I make it cheaper? Is there a way I can make it better? And those are all the things that a company launching a new product might think about if there's other products in the line that they want to sort of compete with. Or a new CEO comes out and says, I'm launching a totally new, first time I'm launching a mobile phone. What do I need to think about? Would people want their email on their phone? Believe it or not, people actually asked that question a few years ago. Would they want to get access to information all the time? And so you have to think through that. How do I price it? How do I sort of continue to develop it? Same thing with you. If I'm launching this new job and I'm going into a hospital where there's other pharmacists, how do I differentiate myself? How do I begin to look different and advance myself in that environment? Or what was talked about earlier, I'm launching a new community pharmacy that has consultative rooms in there. How do I begin differentiating that? How will people want to come there? So those are all the things that you need to think through. So the reality of it is no career is a gradual growth. You will have times of quick acceleration. You'll have times of flat growth. The goal is you want to look back and say, I've continued to advance myself, but the reality is it's not a gradual growth that are there. Now, the other thing I want to sort of bring out is this idea of risk. So I might say, you know what, I'm not interested in launching a new company because I've got a house mortgage I got to pay for. I've got 2 small kids that I need to make sure that I provide resources to. And so the risks of launching and starting a new company might be greater for me than one of you. You might be interested in living in a very small apartment, eating noodles every day to make your dream successful, whereas the reality is I can't do that. All of us have different risks, and we value those risks differently. Some think comfort is important, some don't think comfort is as important. But let me sort of say a couple things about risk. One of which is we always seem to overestimate it. It's never as bad as we might think it is. Secondly, every time you take a new job, there's risk involved. You don't know if you're going to like it. You don't know if the grass is greener. You don't know if you're going to fit in with people. You're not going to know if you're prepared for it. So there's risks there. But the other thing is there's also the risk of doing nothing. So if you think you've got your job that you're most excited about and you don't have to worry about it anymore, there's risk in that because things are changing. Technology is coming out. There might be ways to find people that can do it cheaper than you're doing it, or better. So there's not only risk by taking new jobs and launching into new ventures, there's also risk by staying in your current job and staying as you are. And so that's that idea of ABZ planning. You need to come up with your plan Z. So what can I fall back on if everything doesn't work out? Think about the worst case scenario. So what could happen if I lose my job and I'm unemployed for 2 months? Well, that's not as bad as I think it is. Or some of you say, wow, that would be huge. So many people depend upon me. And so that allows you to sort of think through risk. And the reality is you can't ever predict the future. I mean, we said that quote earlier. We don't know what's going to happen. Things can change so fast. You just have to be ready for them. So the market realities, when you sort of think through that, there's a lot of risk over there. But I do think there is a way for you to be prepared for the future. Can't predict the future, but I think there is a way to prepare the future, and that's called a concept of environmental scanning. So one of which we talked about sort of your network, your colleagues, your mentors, your relationships. They can help you think through what's happening in the future. They might have seen something in their sphere of influence that helps predict things that are happening in healthcare in a few years. Secondly, networking among colleagues. Join professional associations. Be involved in professional associations. Go to conferences. So many things I learn coming here can help me do my job better and be prepared for the future. And read. I remember in college, one of my mentors there said, readers are leaders and leaders are readers. And I've always thought about that. And so I like to read a lot. And while I read a lot of pharmacy journals, I read a lot of non-pharmacy journals. I get a lot out of things that are happening in the lay press and in other sectors that help me environmental scan. And I can see things that are potentially happening out there that will trickle down to healthcare first and then trickle down to pharmacy. And it allows us to get ready and be prepared for that. So I encourage you to always be environmental scanning. So in conclusion, I want to let you know that it's people who help you understand your assets, aspirations, and the market realities. You need to think as an entrepreneur. And the entrepreneur is your own life and your own career. That's the company that you're leading. And when you begin thinking about that, things that entrepreneurs leading new companies have to do are the exact same things that you need to think about personally. So in reflection, do you have a loyalty? I challenge you to write a personal mission vision statement. Have you categorized your assets, your soft assets, your hard assets? Come up with a plan to continue to evolve and develop your soft assets. And then finally, what are your current market realities? Scan the horizon. Understand what trends are happening out there and how can you be prepared for those. Well, I want to thank you for the opportunity to share some of my thoughts. As I mentioned at the beginning, I'll be leading 4 workshops. We'll actually unpack some of this, but we'll talk about it from a more company-driven perspective as opposed to a personal statement. But the reality is that the things that can be prepared between both of them. So I want to thank you for the time. Do we have time for questions, or are we not going to have any? Okay, we have time for a few questions, so thank you.
So we have time for just a few questions, if that's okay, before concluding the session. So where's our... Oh, fantastic. Please state where you're from.
Daniel from Hungary. Mr. Eckel, What do you think for us pharmaceutical students? Good?
Yeah, a little bit louder.
So, what do you think for us as pharmaceutical students are, let's say, our secondary main goal to study? What I'm asking you is that when we finish our studies, what do you think is the most important to get to know better, to eventually get to be some kind of bigger and more experienced professional?
So the question was around, once you finish your studies, what should be your secondary specialty? The best thing for you to focus on is what you enjoy the most. And whatever you enjoy the most is what you're going to continue to do. And you're going to continue to get excited by it, you're going to enjoy it, you're going to learn about it, you're going to want to continue to develop in that. And so you need to think about, what is it that I'm enjoying? I had a pharmacist come to me the other day and said, I think I need to be interested in oncology because I see a lot of oncology jobs in the U.S. opening up. And there's true, that's an area of growth. And I pushed back and said, unless you want to do oncology, you shouldn't focus on that. Because new information's coming out, things are changing, and if you don't enjoy it, you're not going to go home at night and read oncology journals and learn more about it. Whatever you're passionate about, whatever you care about, that's what you need to focus on.
But thank you. But what do you think which actually secondary skill would help us accomplish a checklist of our market realities, the ones you just talked about, knowing who we are selling to, what we are selling, what are our possible...
So if you don't know how to come up with the market reality for your country, how do you best do that?
Yes.
Okay, so I think a great place to start is your faculty members, your professional associations, and interview them, and get to know them, and ask them a bunch of questions of what do they see happening in the future. Secondly, take some non-pharmacy people. Could be physicians, but it could be sort of people in the community. What are your needs? Study after study says the number one concern of patients that go in the hospital is medication errors. People are scared about that. Well, do we go in and talk to patients and say, I'm the pharmacist taking care of you, I'm going to make sure that your care is as safe as possible? Well, if we had learned and understand and know that, then we might take advantage of that. So to me would be talking with people that have experience, both within the sector of pharmacy and those outside the sector of pharmacy, and they can help begin pulling together your market realities.
Thank you very much.
Thank you. One last question, please, if any. Okay, there's one.
Hello, I'm Taslo from Germany. So what I understood is that you're telling people to think of themselves as companies and starting to become companies. So do you see the future, perhaps 5-10 years, more and more people becoming the investments instead of larger things such as in football, where football players are actually themselves the investment per se? Do you see this will go over to, for example, pharmacy and other markets?
Where football players, they get paid differently based upon who's the better striker and who's...
No, in football, you could argue that the football player is the investment and the club buys the player because of the investment chance. And similarly, perhaps for example, Facebook bought WhatsApp mainly also because of the very smart workers. And when do you think this will catch on in pharmacy?
So there's this concept called knowledge workers. And Peter Drucker, famous leadership expert, really came up with this idea. and the employee of the 1970s and 1980s, especially in pharmacy, they had hands, and by having hands, they could do things. And just like an assembly line, who do you value the most? Those that can do it the fastest and do it the best. And so people are interchangeable. Well, somebody's making IVs. Well, I can get somebody who can make them faster, and so they're better for me than the person that makes them slower. What's happening with technology is hands in healthcare really aren't that important anymore. It's the knowledge. And not everybody is the same in knowledge. And so being able to stay in advance of the cutting edge only brings yourself more value to the employer. And so even if you happen to be in a hospital setting or a large community pharmacy setting or a place where there's multiple people around, just by getting the job, you shouldn't say I've arrived. It's how do I differentiate myself from everybody else around me? How do I continue to grow, learn, and become better at what I do? And so this idea of knowledge workers is something we need to realize. The same thing as me as an employer who has many employees. If I've got somebody that's really good, the worst thing can happen is they leave. Because whoever comes back in after that is never going to be as good. So it's my job to keep people satisfied and happy and really enjoying their job. And so that's the dynamic that's playing here. So from that perspective, then, I think it's very important for you, even if you've got a job and you're working hard in it, things are happening and changing around us. So the best thing you can do is continue to get better and just be better than other people. And by doing that, then you can have job satisfaction and hopefully career stability.
Thank you, everyone. I would like to thank all of our speakers for today. We are running out of time, so apologies if you didn't had time to ask your questions. Feel free to come and approach us. I will ask Fahmi to come to do the closing remarks. He has some announcements for you. Thank you all.
Thank you very much for all the speakers at the afternoon session, for today's afternoon session. First of all, I want to give the certificate and a small gift to all the speakers for today. First for Dr. Bruno. And then for Dr. Dagan as well.
Thank you very much. Thank you. Perfect. Thank you. Who am I going to? Yeah?
And last but not least, Dr. Eckel.
Thank you. The port wine we were talking about yesterday. Yes, thank you.
So, thank you very much for all the speakers today. It is a very inspiring program for today, and I feel really delighted to be able to learn something even a little bit from their extensive knowledge and experience in the, as educators and a pharmacist. I have a few announcements before we conclude the whole symposia program. First of all, from our Miss Secretary General, we have some. We are still accepting some application for the chairperson of Eastern Mediterranean Regional Office, and also for the European Regional Office, Regional Working Group, Regional Project Officer, Regional Relations Officer, and for the Pan-American Regional Office, we have the Internal Communication and Coordinator Officer, Regional Project Officer, and the Secretary. So if you are planning to be involved with the Global Student Federation as IPSF, it is a great opportunity for you to apply for this position. The second announcement before we conclude from the RC is for the social activities for today. The bus will start leaving at 8 from the front of the residences, not from the faculty as it's written on the booklet. So please be ready to leave for the Portuguese evening at 8 from in front of the residence. Yeah. That's all for today. Thank you very much for being here for the symposium, and see you tomorrow for the scientific symposium. Thank you.